السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بكم جميعا في مؤتمر الهلال الأحمر الطبي الثالث في الجراحة النسائية والتوليد في القدس الشريف، والذي ينعقد تحت رعاية معالي الدكتور يونس الخطيب رئيس الجمعية. وكعادته الهلال الأحمر يهتم دائما بالرقي بمستوى وجودة الخدمات الطبية وبما هو حديث وعصري، ويتابع كل المستجدات في المجال الطبي والخدمات الإنسانية. نحن ممتنون لحضوركم هذا الحدث الهام الذي يهدف إلى تعزيز التعاون وتبادل الخبرات والاطلاع على كل ما هو جديد في هذا المجال الطبي الحيوي والهام. نتمنى لكم مؤتمراً مميزاً ومثمراً ومفيداً لكم جميعاً. والآن نقدم لكم الدكتور عدوان برغوثي رئيس جمعية النسائية والتوليد نقابة الأطباء مركز القدس.
مساء الخير. المظبوط دكتور عدوان البرغوثي صار معه ظرف طارئ وما قدرش يوصل اليوم، فبناء على توصيته راح أنا أقدم الكلمة بداله. باسمي وباسم الجمعية النسائية للتوليد نرحب فيكم في هذا المؤتمر الثالث لجمعية الهلال في القدس. جمعية الهلال كانت ولا زالت صرح طبي عظيم في مدينة القدس، خرجت مئات من الدكاترة الأطباء الممتازين ولا زالت تعمل على ذلك، بالإضافة إلى وجودها في القدس هو داعم لهذه المدينة، وهي صرح طبي كبير جدا في هذه المدينة. إن عقد المؤتمرات الطبية في مدينة القدس وبدعوة عدد لا يستهان به من البروفيسورية الموجودين في الخارج هو دعم لمدينتنا وللعلم في هذه المدينة. كلنا نعرف أن القدس مدينتنا الحبيبة تسكن قلوبنا جميعا، فأهلا وسهلا بكم في مدينتنا الحبيبة، ونتمنى للمؤتمر النجاح ولشعبنا التقدم، وشكرا جزيلا.
والآن نقدم لكم الدكتور نهاد دعيس المدير الطبي ورئيس اللجنة العلمية للمؤتمر.
السلام عليكم، أهلا وسهلا بكم في رحاب القدس، كل باسمه ولقبه. أهلا وسهلا بكم في رحاب الهلال المقدسي. سيدنا محمد عليه الصلاة والسلام قال: اطلب العلم من المهد إلى اللحد. والسيد المسيح قال: فتشوا الكتب لأنكم تظنون أنه بكم فيها ولكم فيها حياة أبدية. كافة الأديان تدعو إلى العلم واستمرارية العلم. نرجو من هذا التجمع العلمي أن يستفيد الجميع ونستفيد معا وننجح في الإثراء إلى الجميع. باسم كافة الإداريين في الهلال نرحب بالجميع، وأقدم شكري لكل من تعب وجهد وسهر الليالي من أجل إنجاح هذا المؤتمر، وأهلا وسهلا فيكم، إن شاء الله ربنا يوفقنا جميعا.
والآن نقدم لكم الدكتور سفيان بسيط رئيس الهيئة الإدارية لجمعية الهلال الأحمر في القدس الشريف ورئيس المؤتمر.
السلام عليكم. مش راح أطول عليكم. أول شيء باسم الهيئة الإدارية وباسم المجلس الإداري وباسم المتطوعين والعاملين في الهلال الأحمر بنشكركم كلكم على حضوركم، وبنرحب بكل الضيوف، شبكة مستشفيات القدس، بيت ميل، WHO، تيكا، كل الموجودين هون، مركز الصحة العربي، كلهم باسمه شكرا على حضوركم. مش راح أحكي كثير لسبب واحد، طبعا الأميرة بسمة والكل موجود، يعني فيش وضوء لما فيش تيمم لما يكون الماء موجود. راح أخذ الحكي لأخونا وعزيزنا وكبيرنا الدكتور يونس، لأنه هو الأب الروحي والأب وتحت رعايته هذا المؤتمر. شكرا لكم على حضوركم. بس حبيت أحكي شغلة واحدة، أهمية هذا المؤتمر قبل كل شيء وجودكم هون. في هاي القاعة في هذا المكان. هذه رسالة من القلب إلى القلب، من الروح إلى الروح. أهلا وسهلا فيكم في القدس. وجودكم هنا له المعنى الكبير الكبير الكبير. أنتم ما بتعرفوا قديش كان في معاناة لوصولكم هنا، قديش في معاناة من أجل أنه نكون إحنا مع بعضنا في هذا المكان. أهلا وسهلا في المؤتمر الثالث ومش الأخير، وراح إن شاء الله أولادنا وأحفادنا يعملوا مؤتمرات في مبانينا وفي مؤسساتنا. وأهلا وسهلا فيكم. شكرا للكل.
والآن نقدم لكم الدكتور يونس الخطيب رئيس جمعية الهلال الأحمر الفلسطيني.
بسم الله الرحمن الرحيم. مساء الخير، اهلا وسهلا فيكم. صحيح احنا في نوتردام اوتيل، ولكن في جمعيه الهلال الاحمر الفلسطيني. انا بحب اشكر اولا زملائي انه شرفوني برعايه هذا الاجتماع وهذا المؤتمر العلمي الثالث. هذا كان تشريف لإلي، وفي نفس الوقت احراج ايضا ان اكون بصحبه نخبه من الاطباء الفلسطينيين وغير الفلسطينيين، العلماء، الأساتذة، البروفيسورية. وبعتذر لأني أنا مش طبيب، فبالتالي سامحوني أن أكون، ولكن أتشرف في نفس الوقت أن أكون في حضرتكم حقيقة. هذا شرف كبير. الشغلة الثانية، جمعية الهلال الأحمر الفلسطيني حقيقة منذ نشأتها وهي تعتمد المنهج العلمي، تعتمد التخطيط، تعتمد البحث العلمي في كل عملها. وعندما كان هناك حديث عن سلام أو اتفاقية سلام وإمكانية أن تكون هناك دولة فلسطينية، أول ما عملته جمعية الهلال الأحمر الفلسطيني في القدس عام 1989 إنه أسست، والكثير منكم يمكن بيعرفوا، مركز البحث والتخطيط الصحي الفلسطيني. وهذا المركز كان دوره الأساسي تعزيز البحث العلمي في مجال الصحة والطب، وأيضا الإعداد لخطة وطنية صحية فلسطينية، وتم إنجازها عام 94 وأدينا المهمة وسلمنا المسؤولية الوطنية في هذا المجال. بالنسبة لنا القدس مش مكان، في جمعية الهلال بحكي، بالنسبة لنا القدس مش مدينة وليست فقط عاصمة. لمن لا يعرف، القدس هي البدايات بالنسبة لجمعية الهلال الأحمر الفلسطيني. أول جمعية هلال أحمر تم إنشائها في القدس عام 1910، تاريخ طويل بدأ في القدس. وأول مستشفى لجمعية الهلال نساء ولادي أيضا كان بعد 1910 بسنوات، يمكن 1915 تم إنشاؤه في مدينة القدس. وهناك صور بتوثق هذا الإنجاز لجمعية الهلال، واستمر من حينه عمل جمعية الهلال في القدس. وبعد النكبة الفلسطينية كانت أول جمعيتين للهلال الأحمر بتأسسوا القدس وطول كرم، وأيضا كانوا مستشفيين للجمعية سنة 49 و51. بشكركم على هذه الفرصة لي أن أكون معكم. آسف إذا أطلت، ولكن أهلا وسهلا فيكم جمعية الهلال. نتمنى لكم مؤتمر ناجح، وبشكر أخواني في الهيئة الإدارية لفرع القدس لما قاموا به بهذا الجهد العظيم، لكل أطبائنا وأساتذتنا لدورهم ولما سيقدموه خلال هذه الأيام. شكرا لكم.
Hello, can Professor Nicolaides hear us? Hi, Professor.
Hello, Mazen.
How are you? Allow me to introduce you, please. It is with great honor and excitement that I welcome you all to this online lecture featuring our mentor and our inspiration, Professor Kypros Nikolaides, a true luminary in the field of fetal medicine, widely regarded as the father of modern fetal medicine. Professor Nikolaides has not only revolutionized the landscape of prenatal care, but has also been a guiding light for countless medical professionals around the world, including me and including Firas. His groundbreaking contributions has redefined our understanding of fetal health and reshaped the way we approach maternal fetal care. As a mentor of me and as a mentor of Firas, Professor Nikolaides has left an inedible mark on our hearts and our minds. His innovative research, compassionate approach, and unwavering commitment to advancing the field have paved the way for safer pregnancies and healthier lives. Please join me in welcoming Professor Nikolaides, a true father, our esteemed mentor, and an endless source of inspiration.
It is a great pleasure and honor for me to be able to address your meeting. I had promised Firas and Mazen that today I would be with you. Unfortunately, I cannot be. The last few weeks I have had a series of respiratory infections because I am having chemotherapy for multiple myeloma, and my oxygen levels were quite low, so I was not allowed to fly. I'm very sorry that I have not been with you, but I do promise you that in the future, hopefully, if I am in a better condition, I will come. I come from Cyprus, and I grew up with a very close love for the people of Palestine. As a child, one of our great heroes in Cyprus was your chairman, Arafat, and I always have your people in my heart. It was a great pleasure for me to be able to accept Firas and Mazen. So Basil, I cannot see him there. And only last week, I interviewed another doctor from Palestine who will also be joining us, the fellowship, quite soon. For the last few years, my topic of interest has been preeclampsia. I don't know if you can see the slides. Can you see the slides?
No.
No?
No, we can't.
Sorry?
No, we cannot see the slides yet.
You cannot?
No, we cannot.
Okay, let's go back, see what we can do. Share. And the slides must be the slides now. What about?
Yeah, now we are fine. Yes, we can see.
Mazen, can you see the slides now?
Yes, we can see the. You need to open the PowerPoint presentation, and we're okay.
Okay. My topic will be the prediction and prevention of preeclampsia, something that has preoccupied and concentrated our research for the last few years. And the reason for that is very, very simple. Preeclampsia on a worldwide basis is the main cause of death for women and their babies. More than 45,000 women every year die from preeclampsia, and more than 500,000 fetuses and neonates also die as a consequence of this condition. For those of you that are interested in reading the literature, I strongly recommend that you read this important review article that we published last year in the New England Journal of Medicine, which gives an overview on the prediction, prevention, and management of preeclampsia. When I was younger, the definition of preeclampsia was very simple. It was the development of high blood pressure and proteinuria in the second half of pregnancy. But as I got older, life became more difficult. And now preeclampsia has new definitions. You do not need to have proteinuria if you have some symptoms like pulmonary edema or blindness or eclampsia, or certain laboratory tests like low platelet count, high creatinine, and high liver enzymes. And there are two new, widely used diagnostic criteria. The one is by the American College of Obstetricians and Gynecologists, and the other is by the International Society for the Study of Hypertension in Pregnancy. And the criteria from the American College are more strict than those of the International Society. For example, the platelet count in the American College has to be less than 100, whereas in the International Society, it can be less than 150. More recently, in the International Society, they have also included fetal growth restriction. So if you have hypertension plus a small baby, that is also called preeclampsia. And very recently, like last year, they also included in the definition hypertension plus abnormal angiogenic markers. That means low maternal serum placental growth factor below the 5th percentile, or high split above the 95th. So we have this changing definition where in the traditional way we had eclampsia and gestational hypertension. Now, many cases of gestational hypertension are classified as preeclampsia. They cannot see the slides. Can you see? I thought I was told that. Okay. Yes. What about now? Can you see the slides now? Now you can see the slides. Let me just go back again for 2 seconds. This is me. 46,000 women die every year, and 500,000 fetuses or babies die every year. And then I talked about these changing definitions of preeclampsia, where now you do not need to have proteinuria if you have hypertension, plus some symptoms or laboratory evidence of hematological, hepatic, or renal dysfunction. They're also called. Now let us look at how do we go about predicting whether a woman is going to develop preeclampsia. In England, we are taught that when we see a woman at the beginning of the pregnancy, we must ask her 10 questions. And if the answer to the top 5 questions, anyone, is yes, then we say, aha, you have a high risk of getting preeclampsia. But if the answer to the first 5 questions is no, then we ask another 5 questions. And then if the answer is yes, 2 out of the 5, then we also say you're at high risk. The questions are the same in England and in Palestine and in America. And you are at high risk if you had preeclampsia in your previous pregnancy, or if you start the pregnancy with chronic kidney disease, chronic hypertension, diabetes, or autoimmune disease like systemic lupus erythematosus or antiphospholipid syndrome. The moderate risk factors are you are in your first pregnancy. In England, you are over the age of 40. But in America, because it's a capitalist country and they want to make more money, they say over the age of 35. In England, if your body mass index is more than 35, but in America, where everybody is fat, then if it's more than 30. And if the interval between this and your previous pregnancy is more than 10 years, if your mother had preeclampsia, and in America, if you're black or poor, and often, if you're black, you are poor. This is a very simple way of predicting whether somebody has preeclampsia. It doesn't cost anything. Just ask a few questions. But the real question is, how good is this method of screening that today, not 10 years ago, today, they practice in London and New York? How good is it? It's bad. It is as bad as screening for Down syndrome was in 1970. We classify as being at high risk 10%. 1 in every 10 women, we say you are at high risk. And this group that we classify as high risk only contains 40% of the women that will develop cancer. So we misclassify a lot of women and we miss most of the cases of preeclampsia. This is a paper they published before half of you in the audience were born. This is in 1992. And this is when I wrote that we do an ultrasound scan at 12 weeks, and you look behind the baby's neck, you can see a black space. And if the black space is little, it's good. And if the black space is a lot, it's bad. And that may indicate that the baby may have Down syndrome or other chromosomal abnormalities. Until that time, the method of screening was either to ask women, how old are you? Or to do a blood test in the second trimester and measure various metabolites. With maternal age as the method of screening, we used to classify 10% of pregnant women as being at high risk, and this group contained 40% of the babies with cancer. So in screening for preeclampsia, we are where we used to be 50 years ago. And then I proposed that in screening for Downs, we need to combine the information on maternal age and the biophysical test, the measurement of fluid behind the neck, nuchal consistency, and the biochemical test, the measurement of free HG and clay. I have spent the last 30 years doing exactly the same way of thinking in the prediction of preeclampsia. We have developed a method of combining questions from the history together with a measurement of uterine and artery pulsatility index at 12 weeks, the measurement of blood pressure, and the measurement of placental growth factor. And then the English government gave us a bit of money and challenged me to prove to them that our method is better. And we recruited 7 hospitals in London, 16,500 women, and we had a head-on comparison. The method that we use now, the NICE guidelines against the Fetal Medicine Foundation Cribble test, blood pressure, Doppler, placental growth. The Fetal Medicine Foundation is this blue, nice color, which is also here. And this is prediction, preeclampsia before 34, or 37, or after 37. And what did we find? That for each one of those types of preeclampsia, our method detected exactly twice many as the traditional. You would have thought that with this evidence, people would have already changed the method of screening. But you know, when I described nuchal translucency for Downs in 1992, in England, nobody wanted to believe that. But the women believed it, some of the doctors believed it, but the institutions, the government, the Royal College, did not believe it. It took 15 years and a lot of pressure from women, or the government was forced to adopt this method. It was only in 2006 that they asked me then to help the government to train all the hospitals in England to introduce the combined test of screening for Downs. How many years will now take? How many more women will die from preeclampsia before the governments that are preoccupied in investing in nuclear weapons can save some of the money to invest in the health of the population? 10 years, 20, 30, I do not know. We then were told that maybe this method only works in your hands. This is what they used to tell me in 1992. So we did studies in England, in Spain, Denmark, in many other countries. And these graphs that are called calibration and validation show that the method works well wherever you use it. What does this calibration mean in medicine? On the x-axis, we have the prediction, the model. We see a woman and we tell her that your risk of having preeclampsia is 1 in 2, or it's 1 in 1,000. How true is this number? Is it an invention of our brain? Is it real? We then examine many thousands of women and we look at the observed risk. So if you have 100 women that were given a risk of 1 in 2, half of those women should develop preeclampsia. And if you have 1,000 women that are given a risk of 1 in 1,000, then out of the 1,000 women with this risk, only one should develop preeclampsia. And the perfect prediction is given by this diagonal blue line. And these are the results from the various studies. And you can see that the prediction very, very close to the observed incidence. So the test works and it's accurate. This is the result from 5 different areas, regions in Spain. These are the results from 7 different countries in Asia, from Malaysia to Hong Kong, China, Singapore to Vietnam. And the test works. One question that people ask is that, do you really need to do the triple test, measure the blood pressure and the Doppler and the PLG? We are in Palestine, we are poor, but we are clever. We can measure the blood pressure and you can learn to do the Doppler, but you don't have money to measure PLGF. Is it necessary? Well, if we have the money to measure PLGF, then the detection rate of very early preeclampsia before 32 weeks is 90%. Of preterm preeclampsia is about 75%. If we don't have the money to measure PLGF, well, instead of 90%, the detection rate is 83%. Or if you're in a country where the doctors say we cannot do Doppler, but they are very rich. That country is called America. What can we do? Well, you should learn how to do Doppler, but if you are not very clever to learn how to do Doppler, don't worry about it. Use your money to buy PLGF. And then you can still do a lot better than without. That's one thing that you can. There's another thing that in screening, we can either fix the screen positive rate. We say we only want 10% of the population classified as being at risk, or we can say we will fix the detection rate. We want to detect 75% of the cases of preterm preeclampsia, and depending on which type of test that you use, then the screen positive rate may be lower or higher. So if you do not have the money to measure PLGF, well, don't worry about it. Instead of classifying screen positive 10% of the population, you classify screen positive 15% of the population. If you're doing screening for cancer of the cervix, and you have this screening test where if you say it's positive, you need to do Werthein's hysterectomy, then you're very, very reluctant to have a very high screen positive. But if a consequence of a screen positive result is to give aspirin, well, it doesn't matter. You classify 10 or 15% of the population as being screen positive. This is trying to predict preeclampsia. Now, what shall we do once we identify somebody as being at high risk for preeclampsia? In many different countries, the doctors have a disease, a psychological disease called put the woman in bed. There is nothing I know in obstetrics where putting a woman in bed helps anybody except the woman to go mad. I cannot think of any condition. But you go to all of these countries and you put the women in bed for 6 months, 9 months for no reason at all. Bed rest does not prevent preeclampsia. And then in some countries, like in Cyprus, maybe in Palestine, women are walking this big bag full of many, many different tablets, because in our countries, we think that the more tablets you take, the better the doctor, and you are cured from all evil. There is no tablet that prevents you from getting eclampsia, except perhaps calcium and aspirin. Zinc, folate, vitamins, fish oil, omega-3, omega-99, nothing but nothing. There is evidence from countries that are very low in calcium that if we take calcium, then we can reduce the rate of preeclampsia by about 50%. It doesn't really matter whether you give more than 1 gram per day or less than 1 gram per day. Because when I was diagnosed with multiple myeloma, you know, multiple myeloma breaks your bone. The doctors gave me these disgusting, big, white tablets where if you chew them, they taste like chalk. You know what is chalk? When we were students in the primary school and the teacher was writing on the blackboard, that is what calcium tastes like. I hated it. And then I stopped. My bones are all right. Now, the big problem is to identify who are the women that are deficient in calcium, because there's not a simple blood test you can do to measure calcium levels in the blood and then decide who should have calcium. But this is one method of treatment which has been shown in Latin American, for example, countries to work, perhaps. Aspirin. We have taken 27,000 women at first trimester screening by the Fetal Medicine Foundation method. We identified the high-risk group and we randomized them into receiving aspirin, 2 tablets every day, 150 milligrams every day from 12 to 36 weeks, and placebo. And we found that in the group that received aspirin, we reduced the rate of early preeclampsia by nearly 90%, the risk of preterm preeclampsia by 60%, but there was no impact on term preeclampsia. What is also extremely important is that because we were reducing dramatically, 90% reduction of very early preeclampsia before 32 weeks, we were also reducing dramatically the length of stay in the neonatal unit. If you go to Palestine or to London, the majority of the babies that occupy beds in the neonatal unit are babies that are born before 2 weeks. So by giving aspirin and preventing early preeclampsia, we are actually reducing massively the cost of neonatal care. In England, the cost of neonatal intensive care is £2,500 every day. The government gives £1,000 for every hospital for the whole antenatal care and delivery. But every day, the neonatal unit is £2,500. If you stay in the neonatal unit for several days or weeks, the cost per baby is £100,000. You buy a house for £100,000. And it's much worse than that. The babies that stay in the neonatal unit who were born before 32 weeks, they have a lot of handicap. And if you look at the whole life cost of somebody that was born before 32 weeks, it has been estimated that the cost for a country like England is £3 billion every year. Children that grow up because they were born very prematurely. So this is a very important consequence of proper prediction and prevention of preterm preeclampsia. Let us now talk a little bit about term preeclampsia. If a woman today in Jerusalem develops preeclampsia at 26, 27 weeks, there's a high risk that either the woman or the baby will die, and then the husband will be very angry, and then he will also kill the obstetrician. If a woman develops preeclampsia at 40 weeks, who cares? Just deliver the baby and nobody dies. Is that true? The term preeclampsia is important. Term preeclampsia is not important. What is absolutely true is that the incidence of severe hypertension in the mother, maternal mortality and severe morbidity, perinatal mortality, neonatal unit admission for more than 48 hours, and very low birth weight are much more common in the babies that are born prematurely than in those that are born at term. Blue, premature, red, term. However, this is only half the truth, because there is a lot more babies that are born at term than preterm. The incidence of preterm preeclampsia is only about 0.7%, whereas term preeclampsia is 3%. So although the incidence of complications for the mother and the baby is higher, the preterm than term group, the contribution of term preeclampsia is greater than that of preterm preeclampsia. So term preeclampsia is important for the mother, severe hypertension, maternal death, severe morbidity. The high proportion of perinatal mortality and morbidity can also be attributed to delivery at term. So it's not a condition to be ignored. But we have a problem, isn't it? First trimester screening by the Fetal Medicine Foundation triple test identifies only 40% of the term preeclampsia. And aspirin has no effect on term preeclampsia. So what can we do? We need to screen for term preeclampsia nearer the disease. If I want to predict what is the weather in Jerusalem tomorrow, it is much more likely that I will get it right if I make a prediction today than if I made a prediction 3 months ago. And the same is true for the prediction of preeclampsia. If we want to define who is at risk of term preeclampsia, we need to screen at 36 weeks. And this is from many studies that we have done, and latest is nearly 30,000 women, which shows, again, prediction validation of screening at 36 weeks. In the first trimester, the triple test, blood pressure, uterine artery Doppler, placental growth factor. In the third trimester, uterine artery Doppler is useless in the prediction of term preeclampsia. So now the triple test of the third trimester, blood pressure, placental growth factor, and fleet. We then did a big study of nearly 30,000 women. We identified the high-risk group, and we gave them study. I take studying, all people take studying, because it stabilizes your endothelium and it reduces your risk of cardiovascular disease. And since preeclampsia is also an endothelial dysfunction disease, we thought that giving statins would be useful. Unfortunately, it was not useful at all. The placebo are the blues, the pravastatin is the reds, and there was no difference between them. Very disappointing. And I can assure you, it's a lot of work and money to the study involving 30,000 people. Maybe it was too late. So what can we do next? It was a nice study in Chicago by this nice guy, Hoffman, who took low-risk, nulliparous women at 38 weeks, and he randomized them into two groups. One group, he said, you're low risk, your first pregnancy, we let you carry on until you deliver. In the other group, he delivered them at the beginning of the 39th week. There was no difference between the two groups, the early induction against the expectant in perinatal death, but contrary to expectation, the rate of cesarean section was less in the early induction than the expected management group. Also very important was that the incidence of high blood pressure disease was substantially lower in the induction than the expected management. So we have now been doing a study, and we recruited 2,500 women in the trial. I need 4,000, so I will finish by Christmas, where we do screening at 36 weeks in all women. The central growth factor, fit, blood pressure. We calculate the risk, and if the risk is very, very high, we deliver these women at 37 weeks. If the risk is less, we deliver them at 38, 39, 40, so on. We have estimated that by this strategy, we will reduce the rate of term preeclampsia by at least 60%. And it's not only term preeclampsia that we will reduce gestational hypertension, we will reduce fetal distress in labor, and I believe that we will also reduce neonatal morbidity. But we will see. Next time I come to Jerusalem, I will tell you the end of the story. What about twins? Nowadays, 2% of women have twin pregnancies. And as women get older, or they have babies, or as more and more women have infertility treatment, the incidence of twins goes up. We know, and have done several studies, that the relative risk of preeclampsia in twins is 3 times. The incidence of preeclampsia in twin pregnancies is 3 times higher than in singleton pregnancies. But this is only half the truth. Because of course, twins deliver mostly premature. So if I want to have a fair comparison of twins against singletons, I must not look at the whole incidence of preeclampsia, but at the incidence of preeclampsia in preterm baby. And then the incidence in twins is 9 times higher. So all twin pregnancies have a higher risk, substantially higher risk of developing preeclampsia. What can we do in these women? Unlike singleton pregnancies where we prove that aspirin is useful, we don't really know that aspirin is useful in twins, and it is not good enough to say, well, it is good in one, it should be good in the other. And therefore, we have this monster study, which starts off with 250,000 people to identify those that carry twins and randomize them, those that have twin pregnancies, into aspirin 150 milligrams against placebo, and hopefully find out if aspirin is also useful in this condition. We will know that answer in 3 years. 3 years. Let me now come to the end of my lecture and summarize which are the best ways to identify women at high risk of developing preeclampsia. The measurement of blood pressure is always useful. 12, 20, 30, 36 weeks, always useful because, of course, preeclampsia is a disease of high blood pressure. Uterine artery Doppler which is giving you information about impaired placentation. It's only useful for preterm and early preeclampsia, not for term preeclampsia. Placental growth, which is a measurement of placental function, is during the first and the third trimester. The anti-angiogenic factor called FLIT only goes up 3-5 weeks for the clinical onset of preeclampsia. Therefore, it's not a good method of screening at 12 weeks, but it's useful in identifying women that have imminent development of preeclampsia. FAB is a bit about PLGF, but it's not really. Women that get preeclampsia have 3 times a higher risk of dying in 10, 20, 30 years from brain hemorrhage and cardiac disease. And the real question is, does preeclampsia damage their blood vessels and their kidneys and their heart? And that's why they die of cardiovascular disease. Or, more likely, women that get preeclampsia, they do so because already they have predisposition to cardiovascular disease, and preeclampsia is a pure stress test which manifests this underlying cardiovascular disease. In any case, just in case it was useful to predict preeclampsia, we carried out big studies. In this study, nearly 5,000 women at the routine 20-week scan had maternal echocardiography. The vertical black line shows normality. The horizontal lines show different cardiac functions in women that develop preeclampsia. You can see that most of them are normal. Only one thing was very abnormal from 20 weeks, and that is peripheral vascular resistance. So these women that will develop preeclampsia already have a vascular disease. That is why they die 20 years after preeclampsia because of this vascular disease, heart attacks and strokes. So can we use vascular resistance as a predictor of preeclampsia? Well, not so easy to teach all obstetricians of the world do maternal echocardiography. But there's another way. Unfortunately, the videos with these teams, things don't work. There's another way where you can measure peripheral vascular resistance. This is very easy. And many people in Palestine can do that. The woman is lying in bed, take a transducer, ask them to close their eyes, and you put the transducer on their eye, and then you get this very interesting waveform. 2 peaks systole, then diastole. Then you say, but what is this double peak? Blood goes up into the aorta, then into the brain, and the ophthalmic artery, the blood vessel that supplies our eye, the first branch, the internal carotid artery. So the heart contracts and boom, the blood goes up and you get the first systolic wave. But this systolic wave then goes to the periphery, and if you have small vessels in the periphery, it gets reflected and it comes back from the periphery into the heart and up into the brain and into the ophthalmic artery. So the first wave, the reflection of cardiac contractility. The second wave is a reflection of peripheral resistance. We have done studies at 36 weeks and 20 weeks and 12 weeks. The blue line, horizontal blue line, is normality. The red circles are from women that subsequently developed preeclampsia. You can see that whether you look at the first, the second, or the third trimester, a lot of the women that will develop preeclampsia have increased this ratio of the second wave, the peripheral resistance wave, divided by the cardiac output wave. So this, to me, is a very simple test that we can easily do on everybody. I am coming to the end of my lecture. A very nice Indian guy. When you look at him, he looks a little bit old, he looks a little bit thin, he looks a little bit miserable. I spent the last 15 years developing a very simple test. Just have this very little thing, much smaller than a pewter stick, and you push it into your hand, you get a drop of blood, then you do nothing. You have some water to drink because you talk too much. And after 10 minutes, you put this thing in this small reader. It's just like a computer, a pocket phone, and then it gives you a measure of glycosylated fibronectin. We have now done studies in the first and the third trimester. We found that in women that will subsequently get preeclampsia, the red circles, the glycosylated fibronectin is already increased, and therefore, for people in America where they don't learn how to be an artery doctor because it's too complicated for them, they can perhaps do an ophthalmic artery doctor, and you get the same performance of screening. And also in the third trimester, where you may not have enough money to buy PLGF and PLIT, maybe the glycosylated fibronectin would be a simple replacement of that. So, I want to finish with this slide of this beautiful black woman. She was an Olympic athlete, Rory Bowie. She got the gold medal in the Olympic Games. And 3 months ago, they found her dead at home at 32 weeks, and she died of preeclampsia. So preeclampsia is a nasty condition. It kills people, it kills women, and it kills their babies. And today, we have good ways to identify the high-risk group, the first and the third trimester, and have interventions that can prevent. We need to pressurize governments to spend less money on developing methods to kill people, a little bit more developing methods to save. And we need to educate obstetricians that it's worthwhile in producing methods of prediction and prevention of preeclampsia. I thank you very much again for the great honor and pleasure to be with you today.
Thank you. Thank you, Professor. Thank you very much. Thank you for having the time to give us this amazing and insightful lecture. And thank you for all your work you've done. And thank you very much again. Thank you for your time.
Mazen, I don't know if anybody wants to ask any questions or if it's already too much.
Do you have any questions? Thank you, Prof.
Enjoy yourselves.
Thank you. Thank you very much.
Good evening, everybody. Please allow me to introduce my Irish colleagues. It is our great pleasure tonight to have our Irish colleagues who flew thousands of miles and left behind very busy schedules so they can join us tonight and share their valuable knowledge with us, which will improve and affect positively our women's health. Prof. Sean Daly and Dr. Cameron Regan. Prof. Sean Daly, who was trained in the USA, and he returned to Ireland in 1999, where he became the master of the Coombe Women's Hospital, which is one of the busiest hospitals in Ireland, till 2005. And he has a subspecialty in maternal fetal medicine, and he's widely published in preterm labor, IUGR, and his philosophy of care is that evidence-based holistic care for mother and baby. He's a full clinical professor at the Trinity College. Prof. Daly, please join the stage and enlighten us tonight.
Good afternoon, ladies and gentlemen. It is my absolute pleasure to be here with you today. And I'm giving two talks. The first talk is on preterm labour, and then I will talk to you on screening. I want to start my talk with a picture of Dr. Bartholomew Moss. Dr. Bartholomew Moss lived for 46 years, and he wanted to do something for the poor women of Dublin. And in 1745, he opened the lying-in hospital for the poor women of Dublin, and the Red Crescent Society started its mission in the 1950s for the poor women of Jerusalem. And that's why I want to mention Bartholomew Moss, because Bartholomew Moss and the Red Crescent Society had similar aspirations, albeit 300 years apart. And in 1757, Bartholomew Moss then moved from the original lying-in hospital, which was on the south side of Dublin, because it essentially became too small, because the women of Dublin needed better care, and they were arriving in droves to get better care, and he couldn't provide that. So he raised money, and he got 4 acres of land at the top of O'Connell Street, which is the main street in Dublin, and he opened the Rotunda Hospital. And you can see it here. And this is an image from the early 18th century, or the early 19th century. This building here and this building here were built in order to raise money for the hospital, because back in 1757, there was no ability to get money from the government. And I understand that the Red Crescent Society has similar issues as Bartholomew Moss had. The Red Crescent Society, as you know, has a number of different facilities, and all of them, I believe, contribute hugely to the well-being of women in Jerusalem. So, just to talk to you then about preterm labour, I want to discuss the problem of preterm labour, the way that we can predict women who are at risk of preterm labour, the preterm birth prevention clinic, which I ultimately set up in the Coombe and is now running in the Rotunda, the management of women who we identify at high risk, and then hopefully what we can do to try and prevent it. So this is a map of the world, and as you can see, the levels of preterm birth are highest in these countries. What is, to be totally frank, unforgivable is that the United States of America, the richest country in the world, has very high levels of preterm birth, and that's because it is a divided society in terms of how you access care and the difficulties that the poorer people in the United States deal with. And when you look at preterm birth, and obviously the definition of preterm birth is birth before 37 weeks, it's really the earlier preterm birth that we worry about. We worry about babies that are born before 28 weeks or before 32 weeks. As Professor Nicoloides was talking about, these are the babies that we worry about. And the number of babies that are born between 32 weeks and 37 weeks, technically preterm, is actually about 85%. So we don't really worry about them. And what we find is that as we look at different countries across the world, the proportions of early preterm birth are the same. And those are the ones that we really need to try and prevent. And this is what we want to prevent. We do not want to have little fragile people like this in our neonatal intensive care unit or in your neonatal intensive care unit, because they struggle right from the very start. Oh, sorry. The Epicure studies, which were done in the UK in 1995 and 2006, were reviewed, and essentially what they showed was that the survival of babies born between 22 and 25 weeks had increased between 1995 and 2006, and subsequently now it has increased further. However, the pattern of major neonatal morbidity and the proportion of survivors that survive intact remains unchanged. And even though viability is now 23 weeks, we still struggle to achieve good outcomes. The only figures I could find for the Red Crescent Society were in 2005. And then there was 3,413 births, which represented 13% of all births in Jerusalem. 6.3% of those births were premature, and 77%, or more than 1/3 of those babies, ended up in the neonatal intensive care unit. And that's what we want to prevent. So, can we predict women? Well, there are risk factors, and like everything else in life, if you do it once, you're more likely to do it again. So if you deliver preterm once, you're much more likely to do it again. And it isn't just about preterm birth. It's about preterm premature rupture of the membranes, which is obviously a related and similarly difficult issue. The reason, or one of the reasons, that women don't deliver prematurely is because of the integrity of the cervix. And if you interfere with that, if you do LETS procedures or cone biopsies, then you interfere with the integrity of the cervix, and because of that, you increase the risk of preterm birth. But the other risk factor that we are only realizing over the last 5 years is that cesarean sections at full dilatation increase the risk of preterm birth. And I'm sure the majority of people in the audience have performed cesarean sections at full dilatation, and essentially you are making your incision in the cervix because it has effaced and become part of the uterus. And that damages the cervix, and that increases the risk of preterm birth. But even if you take all those risk factors, you only account for about 1/4 of women who ultimately deliver preterm, because most women who deliver preterm have no identifiable risk factors. So this is the clinic that I set up in the Coombe, and it's very straightforward. It's one big room, and here, there's me sitting here, virtually, the couple here, and a curtain there, and behind that, an ultrasound machine. And the essence of the preterm birth prevention clinic is measuring the cervix. And the reason for that is the shorter the cervix, the more likely you are to deliver early. So how does the clinic work? Well, the clinic looks after women who have risk factors. But as I said, most women don't have risk factors. But we like to see women early in the pregnancy. And that is because if you have delivered early, 24, 25 weeks, and your baby has had 3 or 4 months in the neonatal intensive care unit, which we all know is a roller coaster of good days and bad days, that is a scenario that you do not want to repeat. So many women will come in that situation and say, "Doctor, will you put a stitch in for me?" And even though there's no conclusive evidence that it works for those women, I think we should put it in, because psychologically it's very important that they believe they are doing something in this pregnancy that they didn't do in the last pregnancy, and that it may make a difference. So woman choice in this situation, I believe, is important. The other type of stitch that we can use is physician choice, or history-indicated cerclage. So if we, as physicians, believe that a woman would benefit from a stitch, then I think there is a reasonable rationale for doing it. However, if you haven't delivered before 28 weeks and you come in, I would be encouraging you to go down the cervical surveillance route, to come in regularly, to have your cervix measured, and if the cervix becomes short, there is good randomized controlled evidence that putting a stitch in at that stage significantly decreases the risk of early delivery. And we do that surveillance up until 28 weeks. We do incorporate fetal fibronectin, and I'll talk a bit about that in a minute, but just to know that it is part of the clinic. So measuring the cervix is easy to do, but interpreting that measurement is kind of tricky. So most of the research suggests that if the cervix measures less than 25 millimeters, then it is small, and if it measures greater than 25 millimeters, it's okay. But as we know in medicine, a dichotomous interpretation of a value is probably not the way to go. And we're much better off using quantitative analysis. And this paper by E. Veal does that. So you have just cervical length on the perpendicular axis and gestational age weeks on the horizontal axis. And you can see that irrespective of where the cervical length measures, you can interpret that. And this particular normogram is now part of Viewpoint. So if you go into Viewpoint and you measure the cervical length and you plot it, it'll plot on E. Veal's measurements. Now, the normogram, or what you get, isn't as complicated or as detailed as the one that's in the paper, but it's still there, and I personally find it very useful, because if you measure a cervix at, let's say, 18 weeks, and it's 40 millimeters, and then you measure it at 20 weeks or 21 weeks, and it's 18 millimeters, that is significantly shortened. And even though there is no randomized controlled trials to tell you what to do, I think I would be worried about that particular woman. So, QUIP. The QUIP tool is, I personally believe, a very useful tool, and this has been developed by Andy Shannon in London, and I'll talk a little bit more about how you can use it as the lecture goes on. So we have said that only a quarter of women are at risk or have identifiable risk factors for early delivery. So what about the other 3/4? Well, we all know that women come in complaining of symptoms suggestive of labor, and how do you manage them? So I think you take a detailed history. I think many women will come in with uterine activity that isn't really significant. I think then you measure fetal fibronectin. I'll talk a little bit more about that in a minute. And then you examine them, and then you take the values and you use the QUIP. And I'll go through all of that now. So what is fetal fibronectin? So if anybody asks me what fetal fibronectin is, I'd say it's the glue that keeps the pregnancy in the womb, because you can see it here, and it is sticking the decidua and the chorion together. And if you look at the samples taken from the vagina, fetal fibronectin should not be evident in the vagina from 22 weeks to about 34 weeks. So if you measure it and it's there, no more than what I said a minute ago, the quantitative values are important, then you can realistically estimate the risk. So the way you measure it is you pass a speculum, you take a little cotton tip, you put it in the posterior fornix, and you just rotate it. I count to 20. And then you take it and you put it in a little vial, and then you take a couple of drops of that vial and you put it on a cassette and you stick it into the machine, which is on the desk. Now, I was very conscious when I was listening to Kipros's talk about the costs of these things. This fetal fibronectin costs me 30 euros a cassette, and that's expensive. But I think it does have a role, particularly in peripheral hospitals. So if you are in a hospital whereby you cannot look after babies before 32 weeks, and you are wondering, do I transfer this baby from the peripheral hospital to the central hospital, then I think you can justify perhaps the 30 euros. So the quip, and you can Google it, and perhaps some of you have already used it, I don't know, but it is a very useful piece of technology, and it is available for symptomatic women. So the women who come into you in your accident and emergency, you take history suggestive of abnormal uterine action, previous cervical surgery, previous spontaneous preterm birth, because they're at higher risk, previous pre-prom. It is relevant for both singleton pregnancies and twin pregnancies. You put in the weeks, and if you measure the fetal fibronectin, you can put that in. However, you don't need fetal fibronectin. You can use and calculate the quip without fetal fibronectin, and the asymptomatic women are women in your preterm birth clinic. And this is what you get. So you get risks. 33% before 30 weeks, 0.4% within a week, 3% within 4 weeks. And the utilization of fetal fibronectin is in all the protocols in London, and in our new preterm birth guideline in Ireland, fetal fibronectin is an intrinsic part of that. So I do believe that it's useful. So what do you do? Well, if the fetal fibronectin suggests that there's a 5% risk of delivery within a week, then you need to do something. You need to either transfer that woman to a hospital that can cope with her baby, depending on the gestation. But if you're the central hospital, you should admit her. You should consider giving her antenatal corticosteroids. If she's less than 32 weeks and it progresses, you should consider magnesium sulfate. And if she's less than 23 weeks, you could consider a cerclage. So what about preventing preterm birth? Well, I've spoken about the clinic. There is no doubt that smoking cessation may help prevent preterm birth. But I think, thankfully, my understanding is that you're in the lucky position that relatively few women smoke. Is that correct? Okay. Certainly in Ireland, we are not in that position. Faraz is smiling at me. Many of our women smoke a lot. Then you can... Sorry? Okay. You can consider progesterone, a cerclage, and I'll talk about abdominal cerclage in a minute. So just briefly on progesterone. Progesterone, as you know, there are predominantly two female hormones, estrogen and progesterone. While we don't really understand labor, we know that progesterone has a negative effect on labor. We know that if, for example, a woman comes in with an intrauterine death and you want to get her into labor, you give her mifepristone because that reduces the progesterone level. So we understand that giving progesterone may increase or decrease the risk of preterm birth. And the most recent study to look at this was the Optimum study, and it kind of came out with a definite effect, but it did cross 1. That was a bit disappointing, to be honest. But when you combine all the progesterone studies into a meta-analysis, you clearly see a benefit from progesterone. And then the only question is, what progesterone? In the US, they were hampered by the big NIH trial, which suggested that 17-hydroxyprogesterone given intramuscularly was effective. I personally never believed that, because when you look at that trial, the reason that there was a statistical difference was not that the 17-hydroxyprogesterone acetate reduced the risk of preterm birth. The people in that group had the same risk of preterm birth as the controls, but or as the power calculation suggested, but the placebo group had a much higher rate of preterm birth. And the reason for that was that they used castor oil as the placebo. And castor oil, as we know, causes uterine contractions, and therefore there was a significant difference. Okay, 5 minutes. There was a significant difference, not because the 17-hydroxyprogesterone reduced it, but because the placebo increased it. So I think it is now absolutely clear that we should be using progesterone, but we should use vaginal progesterone. So Cyclogest, Pessaries, 200 milligrams a night. So just briefly on the cerclage, the idea of the cerclage is to close the cervix. I don't think anybody really knows why cerclage works. I personally believe that it works because it holds the mucus plug within the cervical canal, and the mucus plug has antimicrobial effects. But the other thing, and I understand I'm stuck for time, I just want to mention briefly, is transabdominal cerclage. First described in 1965. We know the problem is cervical incompetence, and I can assure you transabdominal cerclage works. The people who should have transabdominal cerclage are people in whom you can't put a cerclage in vaginally. So they've had either LETSs or comb biopsies, and there is no intravaginal cervix available to you. The other group that should be considered for an abdominal cerclage are people who have had a failed vaginal cerclage. And the definition of a failed vaginal cerclage is delivery before 32 weeks. So if you've put a stitch in and you've still had a delivery before 32 weeks, then I believe you should consider an abdominal cerclage. And the last reason is because women want it. Now, I get a lot of referrals for transabdominal cerclage. People kind of Google it and find me. And people come in and they want it because they know it works. But I really try and resist putting it in because it is a major operation. And the implications are significant. So I really try and resist that group. And I think I've only done one because of that. Proper placement is the key. So you need it right here, inside the uterine artery, at the point where the cervix meets the uterus. And you can see here, this is where it is. So we've dissected down the bladder and we've put it in there and tied it. And when you look at the back, I use Merceline tape, and it really does work. So the cervix will not open. The challenge is when women have abdominal cerclages and they come in earlier in pregnancy than you would wish, and you're trying to determine whether or not they're in labor or not, because this will not allow the cervix open, but it'll tear through. And that is a kind of relatively tricky thing. You can see it here. Here's the bladder, here's the fetal head, there's the cervix, and right at the top of the cervix, there's the abdominal cerclage. So it's right at the top of the cervix, and those women are delivered by cesarean section. So the cesarean section scar is closed, and there's the abdominal cerclage. So abdominal cerclage definitely works. How do you do it? Well, I believe it's best done pre-pregnancy. You can do it during pregnancy, but as one of my colleagues in the UK said, it's a little bit like braille and coronary artery constriction, because the uterus is big, you can't really feel where it is, so you're trying to abduct the uterine artery and get the cerclage in. It's very vascular, so it's a little bit concerning. But that was the way we always did them. It's only been in the last 10, 15 years that we've done them pre-pregnancy. Laparoscopically or laparotomy, I've done them laparoscopically. I now do them by laparotomy because I can identify exactly where I want the stitch. And to be honest, by the time women sit in front of me, they really don't mind about coming into hospital and staying for 3 days or whatever it is. The great advantage of laparoscopy, and Firas is a huge expert on this, is it improves what you see and it improves the recovery. These women honestly are not worried about that. So thank you very much. I would like to sincerely thank the organisers for inviting me. It's been a pleasure.
Thank you very much for your valuable and very nice lecture. Just a symbol from Jerusalem. Symbol gift. Will you come? Please.
Now we'd like to invite Dr. Reagan to the stage. Dr. Reagan, she was graduated from Galway University with honors. Then she became a consultant in obstetrics and gynecology, and she obtained her fellowship and subspecialty in maternal fetal medicine from Pennsylvania. She's a senior lecturer at the RCSI, and she has special interest and expertise in medical problems in pregnancy. She would like to talk to us tonight about intrauterine growth restriction.
Thank you very much, and thank you, Ayad, for inviting me to Jerusalem to speak to this august audience. And when you asked me what I'd like to speak about, I really didn't know what I should talk about, but it so happened that I was reviewing the national guidelines on fetal growth restriction, and also I was looking after a relative, which is not a very good idea, who happened to have an extremely small baby, which I managed to get to 35 weeks. So it was something that was in my mind, and I thought it was something that is common and applicable to all of our practices and really very important. So I need to go back. So I want to talk initially about the impact of fetal growth restriction, and I suppose then I want to talk about how we identify the small fetus and whether a small fetus is in fact small, just simply small, or is in fact growth restricted. And then I suppose to talk about what is the difference between early and late onset fetal growth restriction and its implications, and how best to optimise care. And so when we identify a baby that's small, and that's defined as a baby that measures less than the 10th percentile from an estimated fetal weight point of view or from an abdominal circumference point of view, we have to consider that there are multiple etiologies. And the first thing you should do, and we should all do this, is ensure that there's adequate dating. We date all our pregnancies in the first trimester, and that helps to prevent us over-diagnosing small for gestational age, or indeed not diagnosing it. Importantly then, in the second trimester is the fetal anatomy scan, because that's when we get to look at the baby and exclude fetal malformations. And that's a really important thing, because many small babies will actually be anatomically or genetically abnormal. The other part that's important when you're teasing out whether this is actually a placentally driven disease is to look at other features which may be impacting. Smoking is a very common practice in our country. Approximately between 8 and 10% of women smoke, and these babies are very small. In addition, there would be maternal medical conditions which may cause a small baby, and there are other nutritional and social deprivation issues which can relate to a small fetus. But the ones that we're really interested in are the placental causes of fetal growth restriction. And these are the ones that are important because they are associated with an increased morbidity and mortality in the fetus. So fetal growth restriction, which is related to placental abnormalities, has an increased risk of stillbirth and neonatal death, adverse perinatal outcomes, adverse neurodevelopmental outcomes, and a risk of adult disease. And the most important thing we can do in order to manage these cases properly is to recognize these abnormalities in advance of And so recognition in terms of our antenatal care is key to improved outcome. And so when we talk about stillbirth, the risk of stillbirth is about 8-fold if it's unrecognized in fetal growth restriction. And we know that with a small baby born at a certain gestation, its outcome will be worse for a baby born prematurely but not fetally growth restricted. And so Gardozzi did a very nice look at the outcomes for all babies, ones without fetal growth restriction and the ones with fetal growth restriction, and found that if you identified fetal growth restriction and managed that baby appropriately, you could reduce the perinatal morbidity or mortality. But in fact, if that case went undiagnosed, then the perinatal mortality or the stillbirth rate approached 2%. So it's really important that we identify these babies. And so we have fetal consequences of being small, and that is stillbirth. And obviously, there's the risk then of preterm delivery of babies that are identified as being small. And if they're very low birth weight, that's an independent risk factor for these babies. In the neonatal period, they can have necrotizing enterocolitis, respiratory distress syndrome, neonatal encephalopathy, and neonatal death in the neonatal period. And in the infant period, they've an 8-fold higher rate of cerebral palsy, chronic lung disease, and neurodevelopmental disease. They also suffer with behavioral problems and learning difficulties. And in adult life, we now know that that babies who are growth restricted have metabolic syndrome, which is associated with advanced atherosclerosis, ischemic heart disease, stroke, and hypertension, and diabetes. And so in all, it is the single largest contributor to perinatal mortality in non-anomalous fetuses, and so therefore it's very important. In addition to that, how growth restricted the baby is very important, and we find that below the 3rd percentile is the group that is at highest risk of stillbirth. And so how do we define a small baby? Well, traditionally we've said less than the 10th percentile, but that's an arbitrary cutoff. So less than the 10th percentile will not identify all babies. We'll identify most babies that are growth restricted, but in fact 80% of those babies will be appropriately grown. So it's an arbitrary definition in a heterogeneous group of women. And there are inaccuracies around the measurement, and the use of customized fetal growth charts do improve our pickup rate, but only 20% are truly growth restricted. And in addition, we need to differentiate the difference between early onset growth restriction and late fetal growth restriction. And that's because they have differences about them in terms of the pathophysiology and outcome and the screening for them. So in the past, we've looked at growth restriction from a placental point of view, and the feeling was that asymmetrical growth restriction was related to poor placental perfusion, that there was head sparing. That meant that the baby's head growth was normal, but the abdominal circumference was small. Symmetrical growth restriction was often considered to be genetic in origin, or in the case of very early onset growth restriction, all parameters were small. And I suppose we're going to talk a little bit more about how we tease that out a bit further. So the condition that's associated with early onset fetal growth restriction is that is associated with placental pathology. So how do we diagnose a small baby? Well, in fact, our overall detection rate clinically is quite poor. So symphysiofundal height will detect about 30% of small babies. And if we actually measure the symphysiofundal height and plot it on a chart, that improves our detection rate to about 50%. But as I've said, if we don't detect the small baby, the risk of stillbirth is increased 8-fold. So it's really very important. Studies have shown that if we do ultrasound at 28 and 36 weeks, we'll obviously improve detection, but that's a high resource modality, and it's not something that we can afford in our hospital. There is the potential to screen at-risk patients. So again, you would look at the past history. If there's a previous history of small for gestational age, if the woman is a smoker, has hypertension, then you might pick up more of the small babies, but we still miss a lot of them. And then what's the best way to detect a small baby? What is the best measurement? We measure biparietal diameter, head circumference, abdominal circumference, femur length, and generate estimated fetal weight. But in fact, the abdominal circumference is the best discriminator of a small baby that there is, with a sensitivity of almost 80%. The other ultrasound modalities that we can use are the Dopplers, and they're very important. Dopplers are particularly important in early onset growth restriction because they identify uteroplacental malperfusion. And we know that when the placenta embeds, and it embeds poorly, the trophoblasts do not invade the spiral arteries, and there is an abnormal uterine blood flow. And the first indicator of that is an abnormal uterine artery waveform, and then downstream the fetus will adapt and have an abnormal umbilical artery Doppler flow. Later, when the fetus becomes hypoxic, this translates into an abnormal MCA Doppler, which relates to cerebral blood flow, and even later the ductus venosus Doppler becomes abnormal. And we'll talk a little bit about that in a moment. So in order to, I suppose, standardize the definitions and optimize the management and improve comparisons between research, a group of experts met in 2016 and developed a consensus around what early and late onset fetal growth restriction was, and this is known as the Delphi consensus. And essentially, the Delphi consensus said that you had early onset fetal growth restriction if it was diagnosed before 32 weeks, and that this was characterized by a spectrum of abnormal Dopplers that involved umbilical artery, middle cerebral artery, and ductus venosus alterations, and that usually reflected poor placental function and was associated with a high perinatal mortality rate. In contrast, late onset fetal growth restriction happens after 32 weeks. It is usually more associated with MCA Doppler abnormalities, and it is associated with a lower perinatal mortality rate, but often is associated with neurodevelopmental impairment. So we have early onset fetal growth restriction is driven by the placenta, there's malperfusion, we get abnormal Dopplers, changes in the umbilical artery to MCA ratios, and a late adaptation in the fetus, which results in hypoxia, absent flow, abnormal ductus venosus Dopplers, and reverse flow. And in addition to that, there are parameters that we can measure which are physiological, which include the CTG and short-term variability and an abnormal biophysical score. So just to talk a little bit about how we can monitor early onset growth restriction, because this is the one associated with severe morbidity and mortality. We can use growth and Dopplers, and obviously we use centile charts. We measure growth on a 2-weekly basis and look for interval growth. We look at the abdominal circumference. We check femur length and estimated fetal weight. But also we have the CTG, which is an excellent tool for detecting fetal hypoxia. A normal CTG practically outrules fetal hypoxia. And we know that the loss of short-term variability is the important thing, that very, very straight line with shallow scallops that you see with a really hypoxic baby. That flattening is called reduced short-term variability. The problem with that is that it's quite objective. And so computerized CTG has been shown to be much more useful in predicting fetal acidosis than regular observation of a CTG. The biophysical is very useful, but it's not very predictive. It's useful in the moment. So you can know from a biophysical score, which is looking at tone, movement, breathing movement, amniotic fluid volume, how the baby is at that time. and a score less than 4 or 2 is significantly abnormal and should prompt delivery. And you can also use that in tandem with the CTG. So we have other modalities to look at these babies. And I suppose our more sophisticated Dopplers look at the ductus venosus Doppler as well as looking at absent and reverse flow in the umbilical artery Doppler. And we understand the ductus venosus responds to hypoxia by dilating, and it increases blood flow to the heart. And when the heart becomes decompensated, if you like, due to increased afterload, there's increased intraatrial pressure, and we see that as a reversal of flow in the ductus venosus, and that's a late finding and should prompt delivery. So just to go back a little bit to talk a little bit about how we know that. So the Truffle trial was a trial conducted across many centres between 2004 and 2008, and it was a very interesting trial. It looked at fetuses between the gestational age of 26 and 31 and 6 weeks. They were randomized to 3 different arms, which included use of ductus venosus, computerized CTG, or a combination of these. And they looked at outcomes which were death or neurodevelopmental delay beyond 2 years. And what they found, and in this study they used computerized CTG, so that's not a modality that's available to everybody, and that's the problem with this study, I suppose, because they found that the best predictor of outcome, of improved outcome, was computerized CTG in tandem with the ductus venosus Doppler in order to time delivery in these babies. They also found that gestational age at entry and birth weight strongly related to adverse outcome. So I suppose arising out of that, if computerized CTG is not available, then the best, I suppose, markers to prompt delivery would be the regular CTG and the ductus venosus Dopplers. And we haven't really moved very far from that at this stage. And so our protocol, and probably everyone's protocol for early onset fetal growth restriction, is predicated by Truffle. And in fact, the Truffle trial showed that in following protocols, outcomes could be improved. So their stillbirth rate was 2.4%, which in over 500 babies of that gestational age was incredibly good. And so we know that the protocols involve increased surveillance, and that's what we should be doing with these babies. But bear in mind that even with a stillbirth rate of 2.5% in Truffle, there were 12 stillbirths. 5 were because of withdrawal of 5 were due to parental decisions about managing the baby by delivery, and 7 were unexpected. So even with intensive monitoring in these babies, babies will die. Our algorithm then arising out of Truffle is for babies that are less than the 10th percentile with increased umbilical artery Dopplers. They will have screening every 2 weeks. They will have Dopplers weekly, and then monitoring can be intensified as required. If the Dopplers become more abnormal, if they become absent or reversed, then they would be counselled regarding delivery if they're very preterm, or they will be monitored according to the CTG and the ductus up to 30 weeks for reverse flow and 32 weeks for absent endostolic flow. So we're going to talk a little bit about late fetal growth restriction, a bit of a different pattern. The middle cerebral artery is the marker really of late onset growth restriction. It reflects a dynamic between the vasodilation in the fetus in response to hypoxia and the placental impairment, and it is much more subtle. So what we tend to use in that situation is the ratio between the MCA-PI and the umbilical artery PI. And when that falls below 1, that baby is in trouble. So why does the MCA-PI matter? Well, it's a response of brain sparing. So normally there's a high resistance circulation within the fetal brain, but when in response to hypoxia, there's vasodilatation that falls, and that's a sign that there is redistribution of blood to the brain, to the coronary arteries, and to the adrenals. So the DIGITAT study looked at timing of delivery in late onset growth restriction, and This was a Dutch consortium, and they looked at induction versus expectant management in over 600 women, and they didn't find any difference in outcome. And all these babies were between 36 weeks and term, and they were thought to be less than the 10th percentile. They didn't find any difference in outcome unless the baby weighed less than the 3rd percentile, and we've already said that's a marker for severe growth restriction. However, they did find a reduced instance of preeclamptic toxemia and low birth weight in the induced group, and arising out of that, and the general consensus now would be that our general recommendations would be if your birth weight is less than the 3rd percentile, the stillbirth rate remains at 1%, delivered by 37 and 6. If the umbilical artery PI is over the 95th centile, delivered by 36 and 7. And if there's an altered CPR, cerebroplacental ratio, in term, deliver by 39 weeks. So what about the future and optimization of care? Well, I suppose we can modify the risk factors. We can advise re-smoking cessation, and that's the single most modifiable behaviour in relation to fetal growth restriction. And smoking remains a leading cause of stillbirth, with a 1% rate of stillbirth in smokers overall. We can treat hypertension, and I would say that in truffle, one of the big impactors on outcome was the co-presence of hypertension, and obviously there's an overlap between preeclampsia and fetal growth restriction. Low-dose aspirin in placental disease, it's obviously has some impact on circulation, and it does improve outcome if you can identify the women who will develop fetal growth restriction. We know that for antiphospholipid syndrome and for certain thrombophilias, aspirin and low molecular weight heparin can help prevent fetal growth restriction. Into the future, therapeutic strategies might be the use of biomarkers such as PLGF or SFLT1. Sildenafil has been looked at. It's a vasodilator, and growth factors are also potential future targets. But what about us? Well, our interest in the COOM is in smoking in pregnancy. We've done some work on it. We developed a randomized controlled trial of an intervention which was a clinic for smoking cessation, which had a smoking cessation therapist, a midwife, and a team that looked after these women. We ran into COVID, but we did have an outcome. We looked at over 400 women, and the women who were in the smoking cessation clinic had improved rates of smoking cessation and improved birth weight. Following on from that, we became interested in vaping, because vaping is now the new thing, and it's obviously very common. The problem with vaping as opposed to nicotine replacement is vaping is like nicotine replacement on steroids. People vape a lot, and they vape a lot of stuff, and we don't even know how much. We do know that nicotine affects the fetal brain. Our researcher, we did a little retrospective study, and we found that growth is not as impacted by vaping mothers. So women who vape don't have babies that are as small. As smokers, they're more like the normal, but we don't know what nicotine is doing to the developing brain. So we've received a grant from Science Foundation Ireland to look at the outcomes in women who vape or smoke in pregnancy, look at their obstetric outcomes, their infant neurodevelopmental, nutritional and psychological outcomes over a 4-year period. So we will await and see the outcome of that. I just want to finish by saying thank you so much for inviting us to talk today. Thank you.
Thank you very much. Doctor.
May I introduce Dr. Maher Maaita. He's a senior consultant and obstetrician gynecologist in the private sector in Jordan and Al-Abdali Hospital. He's the head of the department at King Hussein Medical Center, Amman, Jordan, and the clinical associate professor, Faculty of Medicine of Jordan University. He's going to lecture an interesting subject, maternal mortality and morbidity, globally and locally.
Thank you very much for the invitation. until recently, I was the head of department at King Hussein Medical Center, which is the largest teaching hospital in Jordan. And this subject, maternal mortality, is a big issue in Jordan, and we're working very hard and looking at statistics and looking at surveillance to reduce it. So I'll just take you through some slides to cover maternal mortality globally and the problems with maternal mortality. And then I will tell you about our journey in Jordan and what we have been doing over the last few years and what we are doing to reduce maternal mortality. As you all know, maternal mortality is the death of a woman from any cause related to or aggravated by pregnancy, delivery, or post-mortem, 42 days, and not from accidental or incidental causes. That's the WHO definition. Now, maternal mortality ratio is the number of maternal deaths per 100,000 live births. Unfortunately, every 2 minutes a woman dies from causes related to pregnancy and childbirth, and that's a very sad fact. And again, globally, around 80% of maternal deaths are related to obstetric complications, mainly hemorrhage, sepsis, unsafe abortion, preeclampsia, eclampsia, and prolonged obstructed labor. And complications of unsafe abortion accounts for almost 13% of maternal deaths. The sad thing is that 70% of those deaths are preventable. So if you follow guidelines, if you have good maternity units, if you have good staff, if you have good training, if you have protocols, then you can reduce maternal mortality. Now, look at these figures. I mean, 300,000 almost women worldwide lost their lives in 2017. Unfortunately, most of them in Sub-Sahara Africa, South Asia, accounting for approximately 86% of all maternal deaths worldwide. So you have regions where the maternal mortality is much worse than others. And I'll be talking about that. Again, globally, almost 200, the maternal mortality rate is around 223 per 100,000. That's worldwide. But you'll find high in some regions, low in others. Now, every day, almost 800 women die from preventable causes related to pregnancy and childbirth. And between 2000 and 2020, maternal mortality rate dropped worldwide, average 1.7 per year. And that's what we're targeting. Almost 95% of all maternal deaths occurred in low and low middle income countries. And that's the sad statistics. And if you look at this slide, you can see that the worst is Africa. The best figures are in Europe, and our region is in the middle. And now, unfortunately, our region is affected by wars, and our statistics is even worse than what is on the slide. And if you look at this slide, you can see the variation. If you look at Europe, I mean, they have excellent figures when it comes to maternal mortality rate. I mean, Norway, Germany, Australia, Austria, UK, excellent figures. I mean, it's sad that they're still losing ladies, but they work very hard on preventable causes, and they have guidelines, and they have confidential inquiries. So they are learning the lessons. So they're studying the cases, they're putting some protocols and guidelines, and they're following them. But if you look at Nigeria, for example, Congo, Afghanistan, where they've been in wars for the last 30, 40 years, the figures are much worse. Now, if you look at the countries, now I can tell you that the 2 Arab countries that they have good statistics related to maternal mortality now is Jordan and Egypt. Why? I'll tell you in the next slides. But this is what is being published by the WHO. Again, if you can see, some countries have very bad statistics while the others. Now, the Gulf region, they have good statistics because they don't have many deliveries and they have money and resources. Our region is in the middle. I mean, Jordan was reported as 41, but I'll go through our statistics. It's less than that. Palestine was reported as 20. I'm not sure what's the accurate figure, but if it's 20, then compared to the neighboring countries, this is a good figure. What are the main factors that prevents women from receiving or seeking care? Because at the end of the day, if she fails to seek care, then that's the problem. And we've heard about preeclampsia earlier on, and it's still one of the main causes of maternal mortality. Obviously, poverty, distance to facilities, lack of information, inadequate and poor quality services, and cultural beliefs. All these factors will make it difficult for a lady to go and seek medical care. Now, the high number of maternal deaths in some areas of the world reflects inequalities in access to quality health services. And there is a huge difference between countries, as I demonstrated in the previous slides. So, ranging from 462 to 11 per 100,000. So, a huge difference in figures. Now, again, as you know, there are the Sustainable Development Goals. We need to identify the number and causes of death, and the target is to reduce maternal mortality worldwide. That's the aim, and so that it will have better figures, and you need a reduction of almost 11% every year to reach the targeted figures that the UN is looking for. Now, I'm gonna, in the second part of my talk, just to cover the Jordanian experience with our journey with maternal mortality, and I'm very proud to say that we worked very hard, and I'm part of the committee or the higher commission with maternal mortality, and we have different committees, and at the end of, we managed to publish 4 reports covering 2018, 2019, and 2018, 19, 20, 21. So our aim is to establish a Jordanian maternal mortality surveillance and response system. And what we mean by response system is to look at cases, learn the lessons, and put protocols and guidelines to reduce the maternal mortality. So as you know, Jordan is a population of almost 12 million people, women of reproductive age 2 million, total fertility rate is around 2.7, number of deliveries around 200,000 per year, plus minus. We have good health system. Most of our ladies, they deliver in hospitals, and cesarean section rate, it's reported here in 2018 as 25.8, but I will argue that it is higher than that. If you look at the private sector and the public sector, it's around 40%. So it is high. And if you look at Egypt, for example, I was surprised to hear that the rate, the cesarean section rate is 80%. And that contributes to the maternal mortality, because if you are doing high rates of cesarean section, then obviously you are going to be facing placenta accreta, you're going to be facing hemorrhage, you're going to face lots of problems, and it will reflect on your maternal mortality rate. So definitely, we have high cesarean section rates in our region. And that's something that is challenging for all the obstetricians here, Jordan, Egypt, everywhere in the Middle East. And that's why 2 years ago, we had a MENA PAS meeting, which is a placenta accreta spectrum meeting in Egypt. We want to learn the lessons. We want to know what are we doing, how can we reduce the cesarean section rate, because placenta accreta spectrum is a challenging problem in our region. And it's everywhere, by the way. And we had a meeting in Amman last year. Maybe some of you attended that meeting. We're going to Riyadh next year and to Baghdad the year after. So this is before our project. That's the reported maternal mortality in Jordan before we started our confidential inquiries, if you like. And as you can see, it ranged between 73 to 19 based on surveys and estimates by the WHO. And unfortunately, the WHO will report some figures, but they're not accurate, especially in our region. So what happened is, by law in 2015, there was a bylaw 10, which was approved in 2015, that all maternal deaths had to be notified. So any maternal death in Jordan had to be notified to the Ministry of Health in the productive age 15 to 49. and it's all the responsibility of the Ministry of Health. So it's a national system, to quantify maternal mortality ratio, active surveillance, assign main cause of death. That's the most important thing. So we will know what's happening in the kingdom, because in Jordan we have tertiary hospitals, but at the same time we have peripheral hospitals in the south and in the north, and they are not well staffed like teaching hospitals. So it's important to know what's going on and define contributing factors and response to avert similar deaths. So that's the main, to report the cases, look at them, study them, learn from them, then response, and then hopefully we will work on reducing the rate. So the target is to eliminate preventable maternal deaths. And this is the process that we were following. We have all the hospitals by law had to notify a maternal death with that certain age within 24 hours, then identification with 72 hours, all reported by computers, and then the facility or a committee will review all the deaths, household, national, at the level of the facility, analysis are done, response dissemination, and then monitoring. And it's all was designed as a secure web-based application, so all the information which was reported is confidential. And as I said, report, generate timely maternal mortality data, quantify the maternal mortality ratio for Jordan, and then work on the response, identify avoidable factors of maternal deaths, and formulate an appropriate response to avert similar deaths in the future. And when I go through the reports, I'm sure you will feel that you will have similar problems here in Palestine. Now, we followed the WHO or what's been reported in the literature about the 3 delays. So either a woman will delay in deciding to seek health care. If she has headache, for example, she will stay at home 2-3 days, and then when she goes to the hospital, she will be, they will find that she had preeclampsia. So a delay to seek help, delay in reaching the hospital, and then the third one, which is the problem, is delay in receiving adequate health care. The project was launched in 2018, and so far I'm very proud to say that we managed to publish 4 reports. 2018, as I said, as you can see, 2019, 2020, 2021, and now we're finalizing the report covering 2022. So what did we find? And if you look at this slide, you can see the number of maternal deaths, number of live births. And remember that you have to have a ratio per 100,000 deliveries. So in 2018, we had almost more than 207 deliveries. And unfortunately, we had 62 deaths. These are confirmed maternal deaths. So that will make the ratio 29.8. In 2019, we had 63 deaths, and that's the total of deliveries. So the ratio went up 32.4. 2020, we had 53 deaths, the ratio is 30, but we had less deliveries. And the last report, we had 56 deaths, 29.8. So we can confidently say that the maternal mortality ratio in Jordan is around 30, plus or minus. That's without the COVID. Sadly, I'll show you the next slide, that in 2020, if we include, now lots of countries, when they publish maternal mortalities during the COVID area, they publish 2 reports, one with COVID, one without COVID. So if you looked at the without COVID, we confidently can say that it's 30, plus or minus. So we need to reduce it, but we did not reduce it because it takes more time to reduce maternal mortality, and maybe we're better at reporting now. But sadly, if you look, in 2020, we lost more COVID cases, and the ratio with COVID is 38, but the worst year was 2021, and look at the ratio, 85. So we lost almost 100 ladies with COVID. So we did not do very well in Jordan when it comes to pregnancy and COVID. And maybe lots of countries did not do very well as well, because we're not familiar with how. Anyway, maybe at the end we managed, but sadly COVID was disastrous for pregnant ladies in Jordan. Causes. If you look at that, 2018 postpartum hemorrhage, followed by cardiovascular, followed by pulmonary embolism. 19, hemorrhage, pulmonary embolism, hypertension. But look at 20, COVID-19, COVID-21, COVID. So COVID was #1 killer of pregnant ladies in Jordan in 2020, 2021. But postpartum hemorrhage is still the top. Why? I'll just show you. 17 ladies lost their lives from hemorrhage, 18 in 19, 11, 26, 13. Most of the deaths happened postpartum, 60% or more, 75%. Postpartum is a very critical area. And I'm sure if you do proper reporting in Palestine, you will find similar data as we did with what we've done. Now, delay in receiving care. Look, delay in receiving care rose almost 41%. That's bad. So that means the woman goes to the hospital and she's not receiving an appropriate care. Why? Maybe because there is a lack of standardization protocols, the lack of senior obs and gynae experts, a delay in determining the proper clinical decision. And that's been reported in the confidential inquiries of the UK years ago, that the juniors do not talk to the consultants. By the time they talk to the consultant, it's too late. The woman dies from bleeding. Some hospitals that don't have blood banks. This is a summary of 21. As you can see, the rate is 30 almost. This is the number of deliveries. COVID was a problem, postpartum hemorrhage, pulmonary embolism, 75% avoid. This is just to show you that the maternal death by timing of death, as I said, most maternal deaths occurred in postpartum period. So postpartum is dangerous, and you need to make sure that after delivery you need to observe the woman. Most of the deceased women had 4 and more antenatal visits, and that tells us, maybe like Palestine, the woman will have 10 visits, but you don't have people doing the right thing in the antenatal clinic. They do scans, but they don't know, they're not very qualified to do a proper scans. I mean, in Europe, in the UK, I trained in the UK, we offer 2 scans. At the time when I was in training, early scan and detailed scan, and if they need more scans, they will have more scans. I was surprised to hear in Ireland that you offer 4, or is it in your clinic that you offer 4? 2. But if it's IUGR, then you offer. Okay, sorry. Maternal deaths by mode of delivery, we found that maybe 50 or 60% of those ladies who died, 60% of them had, plus minus, had cesarean section. So we have a problem with the cesarean section. Is it the indication? Is it we don't have proper assessment? Is it the anesthesia? This is an area that we need to investigate more. Direct or indirect causes, as you can see, the direct causes are higher, but the important slide here, if you look at avoidable, look, 69% avoidable in 18. In 2019, 82% are avoidable. So if we work on the avoidable cases and reduce them, then our maternal mortality will be like Europe. It will come down from 30 to 10 or 15. Again, there is a delay in level 3. So the lack of standardizing, as I said, the protocols, lack of senior obstetricians, delay in determining the surgical decision. So I think it's very important to work on the response. So what are we going to do about maternal mortality in Jordan? We need to study. We need to look at the community, the facility, national level of response, and we have to have a plan, short-term and long-term, and hopefully bring it down. These are the kind of response that we're working on. Adopt strategies to address the most common causes of maternal death. Obviously, hopefully we're not going to have COVID again, but we need to address hemorrhage, preeclampsia, pulmonary embolism. We need to adopt strategies to enhance the quality of antenatal care. We need to reduce unnecessary cesarean section, as I discussed earlier, and we need to increase the uptake of quality and effective family planning methods. And these are the strategies that we're working on now. And again, we need to work on the quality, evidence-based medicine protocols, safe and adequate blood and blood products, documentation and quality of data. We need to work on adequate qualified staff. We need to continue capacity building is needed, and these are the pathways that we're working on. And to be honest with you, I think we would not have done that without the support of US aid in Jordan. I have to accept that, and I have to admit that, because as you know, all our governments are the same. You have to have some support. And the US aid supported us on these projects, and they're still supporting us, but they have a 5 years period, and after that, we have to depend on ourselves. Now, what are the path forwards? That's what we're targeting, and that's what we're doing to take this project forward. So, maternal mortality guidance principles for response, obviously we have to look at avoidable factors. We have to follow evidence-based medicine. We have to look at our actions, feasibility, resources, health system readiness, and establish a timetable, immediate, short, long-term plans. And we have to integrate recommendations. We have to decide how to monitor progress and how effective is our plan. We have to monitor to ensure recommendations are being implemented. And these things are very important. Now, maternal mortality reduction require concerted efforts from all levels of healthcare system, from the community up to the central headquarters of all health stakeholders. And obviously, maternal mortality reduction takes time. You cannot do it in 1 or 2 years. We're looking at maybe a 10 years period before we are confident that we can reduce it. And in conclusion, unfortunately, maternal mortality remains a critical global issue that demands urgent attention and multi-sectorial actions worldwide and to end preventable causes of death. Jordan succeeded, I think, in establishing a system that provides accurate data for evidence informed decision making, and we succeeded, or Jordan has the capacity and commitment to implement this system, and dedication for timely reporting and appropriate funding are essential if we want to succeed. No woman should die while bringing life into the world. I thank you very much for listening.
شكرا دكتور ماهر، محاضرة جميلة كانت، ونشوفك كل سنة إن شاء الله.
Our last speaker before the break is Professor فراس أبو سعادة. دكتور فراس هو ابن المقاصد. Professor Firas Abu Saade, he is a consultant gynecology oncologist and pelvic surgeon at St. James Hospital, clinical associate professor at the Department of Gynecology Oncology, Institute of Molecular Medicine, Trinity, Dublin.
مساء الخير، السلام عليكم. لعل ما يضبط البرزنتيشن. I would like to thank Iyad, the organizing committee, for inviting me here. It's really my pleasure. I'm very happy to be back in Jerusalem. زي ما حكى الأخ بسام، أنا ابن المقاصد. I did my initial training here in 2000 before I moved to Ireland in 2005. I have a great memory here in Jerusalem. اتعرفت على زوجتي here in Jerusalem, so I knew Nida shown here in Jerusalem. She was working in the الهلال and I was working in مقاصد. So كان في قصة حب عظيمة. أنجبنا 4 أولاد, so I think it's successful story. So for these reasons and many other reasons, this city means a lot for me. And also, before I start my presentation, I would like to thank Sean and Carmen for making all the hardship to come from Dublin to Jerusalem. I know how busy both of you, so really, genuinely, thank you very much. Now, when Iyad asked me to do a presentation for today. I asked him what's the theme for the meeting, and he said innovation in gynecology. And my specialty is oncology. So I thought about different kind of cancers. And as far as I remember, the most common cancer here is endometrial cancer. So over the coming 20 minutes or so, I will focus on endometrial cancer in terms of epidemiology, staging, treatment. And on treatment, I'll be focusing mainly on controversial point on surgery, lymphadenectomy, adjuvant treatment, and I will touch quickly on new treatment and on young patient. So if you think of endometrial cancer, the prevalence is something around 30 per 100,000. So 30 by 100,000 doesn't mean anything really. But if you think in real number, in Ireland we have roughly around 350 cases a year. Ireland population is more or less 5 million, which is more or less like Palestine. Like when I say Palestine, I mean by that West Bank and Gaza. I don't mean historic Palestine. So you can think of endometrial cancer, you may have here around 350 cases a year. I think this is important from strategy planning and organizing how many gynae-onc center you need in the future, how many consultant, trainee, etc. Now, if you think as an individual, your personal risk of having endometrial cancer is something between 2 to 3%. The peak age in early 60s, and unfortunately, the risk is increasing. So early 2000, the prevalence rate was 20 per 100,000, but lately, late 2020 is something around 30 per 100,000. And if you wonder why, you just look how many McDonald's open in Jordan. We don't have McDonald's here in Palestine, alhamdulillah, lissa, but I'm sure it will come. So obesity is one of the main factors to blame for endometrial cancer. If you look at this world map back in 2020, it looks fantastic, nice and bright. ألوان وردية وجميلة وحلوة. It was the rate of obesity was something between 14 to 20%. But if you look at now, it's more purple in color. So endometrial obesity is something in 40s. So definitely we can blame obesity for the rise in rate of endometrial cancer, but we shouldn't forget other risk factors. Now, saying all of that, the good news, the prognosis from endometrial cancer is excellent. So for all stages, the 5-year survival is 80%. And for stage 1, it's something 95%. And for certain type of stage 1 endometrial cancer, which I will touch on it later, it's almost 100%. So even if you have an endometrial cancer, if it's a certain type, you'll be cured from it if you have a certain genetic abnormalities. If we come to the staging, when I look in the history book, I find this is the first staging system back in 1953. وزي ما بوصفوه احيانا في الفيسبوك العصر الجميل, the nice age at that stage. I'm sorry, this slide is over the place. Anyhow, the stage at that stage was 2 stages: stage 1 and stage 2. With the stage 1, cancer is in the uterus and operable. Stage 2, cancer outside the uterus and not operable. Now, the current staging system we use is this one. This from 2009. Which look a little bit complicated, I agree with you, but it's pretty more or less simple. Stage 1 confined to the body of the uterus. Stage 2 move to the cervix. Stage 3 around the uterus, vagina, ovary, fallopian tube. And stage 4 have a distal metastasis. Now, if you think this staging system is complex, wait until you see this one. So this is the one which is suggested by FIGO in 2023. And honestly, I work on this field. This is the only thing I do, and I cannot remember this staging system. And I don't think anyone will remember this staging system. It's extremely complicated. There's a huge reluctance for most of the gynae-onc center to adapt it. Right now, literally right now, there is a webinar in the ISGO talking about this staging system. Should we adopt it or we should not? And I think what they try to do with this staging system, they try to give a personalized prescription for every cancer, for every woman, what kind of the most appropriate adjuvant treatment for the cancer. And I think this is where they fail. because the idea from any staging system is not really to give a prescription for the treatment for the cancer. The aim from any staging system is really to describe the extent of the disease. And we can compare different centers and different outcome. And I think here where the guys in FIGO, they missed the boat. And I said there's a huge reluctance to use this staging system. And you know, if you think for up here, for example, they include metastasis to the ovary as a stage 1. In the old system, that was stage 3C. It's completely different. If you look here, stage 3, they have 3C1, 3C2, and that need micrometastasis. And you need a special pathology lab with a special pathologist who can pick up these micrometastases. So it's not really applicable in most of the centers. But if you ask me about innovation in gynae, this is the innovation on the staging system. Now on the treatment, I'm not gonna describe everything how to treat an endometrial cancer, that's well known and well established. But I'm gonna talk about some of the controversial points in management of endometrial cancer. So I'll talk about minimal access surgery, yes or no. About lymphadenectomy, should we do it or no? And about sentinel lymph node sampling. So if we start with the route of surgery, I think we moved from open surgery on the left-hand side, delivering such a huge specimen through a big midline scar. That's what was happening in 1980s and 90s, to the picture on the left-hand side, where it's 2 scars, 2 small holes with minimal access. So we moved from the picture on the left-hand side with an empty pelvis to a more conservative treatment with the picture on the right-hand side. Now, minimally invasive surgery is the preferred approach, including all patients, low risk and high risk. There's a huge evidence of randomized controlled trials supporting the use of minimal access in endometrial cancer. So that question is completely answered. I don't think anyone will open that question again. Now, if you're doing it with minimal access, try to avoid any intraperitoneal spillage of the tumor, either by making a mini laparotomy to deliver the uterus or put the uterus in an endo bag. So as I said, there's a huge amount of evidence. It's a randomized controlled trial back from 2010 and after. And I will show you these 2 trials. The first one, it looks into around 760 women. They randomized them into open or lab hysterectomy for endometrial cancer. And if you look at the Kaplan-Meier curve, on the left-hand side is the risk of recurrence, and on the right-hand side, a risk of death. And the 2 curve for the one with the yellow with the minimal access surgery and the one with the blue for open surgery, the 2 curves is almost exactly the same. So it's well established, there's no difference from oncology outcome between minimal access or open surgery. The other randomized controlled trial, which also published back in 2012, is the LAB2 trial. And that trial, they recruit more than 2,000 women, and they randomize them 1 to 2. So 1 open versus 2 with lab. And the Kaplan-Meier is exactly the same. So there's no difference between recurrence or mortality. Overall survival was exactly the same between the 2 arms of the study, either open or lab. Now, saying all of that, I think we need to take this with a bit of caution. I don't know if you remember back in November 2018, when this trial came out, and it literally changed the practice of gynae-onc overnight. So up November 2018, we used to do all cervical cancer radical hysterectomy with laparoscopy. And then this trial came out in the New England Journal, and overnight, we stopped doing laparoscopic hysterectomy for cervical cancer, because that was the Kaplan-Meier for this trial. So the odds ratio for dying from cervical cancer, if you have your surgery with laparoscopy, was 6 times compared to open surgery. Your chance of dying is 6 times just to have a minimal scar rather than having a traditional scar. And for that reason, overnight, we changed from minimal access to open, and no one now offers a radical hysterectomy for cervical cancer through a laparoscopic approach. Now, the next step, the next point I will talk about it is lymphadenectomy. And lymphadenectomy is one of the most controversial issues in gynae oncology for the last 20 years. It hasn't been resolved, and I don't think it will be resolved for the coming 10 years or so. The question always to do it or not to do it. If you're gonna do it, what level you should stop? You should stop here at the pelvic brim. You do para-aortic, and if you're doing para-aortic, should you go to the IMA, or should you go all the way to the renal artery? And the big question really was, is there any therapeutic benefit for doing lymphadenectomy in endometrial cancer or no? So until early 2000, everyone was believing by doing a full lymphadenectomy, you increase survival for women with endometrial cancer. Now, the evidence for that was coming from this trial, which published in 1987. That's called GOG33. On that trial, they simply look in retrospective way. It wasn't a prospective randomized control trial. So they look at retrospective in all cancers, which assume to be early stage. And they look and they see after the surgery, how many of them they have lymph node metastasis and local spread. So on that trial, they find quarter of the women who thought to be an early stage, they have really metastasis outside the uterus. And out of those, 12% they have lymph node metastasis. Now remember, that's 1987. And for that reason, the approach was every woman with endometrial cancer to have a full lymphadenectomy. But remember, the aim from this study wasn't really to test if there is any therapeutic benefit, is there any increase in survival rate, is there any decrease in recurrence rate by doing lymphadenectomy. And that was the approach until late 2009, 2010, when there's two important randomized control trials about lymphadenectomy in endometrial cancer published. The first one is the ASTIC trial. I'm sure you're familiar with the ASTIC trial. And on that trial, they find pelvic lymphadenectomy did not really increase survival at all. And they said pelvic lymphadenectomy cannot be recommended as a routine procedure. And the second trial, the year after that, also the conclusion was doing a full pelvic lymphadenectomy will not increase overall survival. Now, despite these two trials were a randomized controlled trial, similar to the LAC trial, which I shared with you earlier, but these two trials, they failed to change any of our practice. So we're doing lymphadenectomy. And the reason is these trials been criticized hugely by the gynae-onc community. The sample size was small. It wasn't powered enough to answer the question. The surgeon who did the surgery, they're not trained enough. There's no enough lymph node removed, et cetera, et cetera, et cetera. And I think this is a lesson for all of us who are doing research and clinical trial. If you're doing a clinical trial which is going to answer a very big question, I think you have to design it very well and properly. Anyhow, so that's the outcome for now. And to answer that question, there is currently two randomized controlled trials. This one, the first one, CIPAL, which is due to finish recruiting patients in 2025. And remember, after that, they have to wait for 5 years to check overall survival. So you can expect an outcome 2030. And the other trial is the ECLAT, which her protocol published in 2021. We are in James's part of this trial, due to finish recruiting 2027. So maybe 2033 or 34, we will have some sort of outcome. I'm sure I'll be retired at that stage, and maybe my son or somebody else will be doing that job. So what is accepted now in most of the gynae-onc centers is that lymphadenectomy in endometrial cancer, you can avoid it if the patient has an endometrioid cancer, a grade 1, and no myometrial invasion. And if you really want to push the powder a little bit, if there is myometrial invasion, it should be less than 50%. And that is taking me to the next step, which is the sentinel lymphadenectomy. And this is what we do in our center in James's, which we find is a middle ground between not to do lymphadenectomy and to do a full lymphadenectomy. So the sentinel lymphadenectomy, the sentinel lymph node, how you define it as the first node draining the tumor. It doesn't matter where that tumor is. And because that node is the first one draining the tumor, so, common sense, it should be the higher node, the node at higher risk of harboring metastasis. And you can pick up these sentinel nodes through different methods. Blue dye, either methylene or patent blue. You can do it with technetium-99. The problem with technetium is expensive. The injection should be done while the patient is awake, which is painful. I have a personal experience myself. It's extremely painful. I don't wish it to any patient. and you need a radioisotope department, your nuclear medicine department in your hospital. The most accepted and used method of sentinel lymph node is ICG, indocyanine green, which is quite cheap. All what you need is the injection itself, a syringe, and a speculum. And you know, the usual laparoscope you have, most of you use, you just need to upgrade it to infrared, which is not very expensive. And it's very simple. You inject the dye on the cervix at 3 and 9 o'clock, and you don't have to wait too long, because with the technetium, you have to wait. With the ICG, you don't have to wait. So within 20 minutes, you'll find your node is already stained with the green, and you progress your surgery. There's other method of delivering the dye, so you can deliver through the hysteroscope, you can deliver through laparoscope, subserosal, but again, there is enough evidence to say that positive predictive value in picking up the sentinel node through the cervix is as good as other method. So sentinel lymph node is very well established in other cancers, like with our colleagues with breast cancer and melanoma, they don't even mention the word full lymphadenectomy. Their practice is just doing sentinel lymph node. And it has been introduced to gyne-onc, mainly in endometrial, and to some extent into cervical cancer. Now, this is a very short video, and it happened for the same patient. So on the right-hand side, this woman had a full lymphadenectomy. And on the right side, she had a sentinel lymphadenectomy. And you see the sentinel, you have a very nice anatomy. You have the ureter here, easily seen. You see the external iliac vein. And here you see the uterine artery. You remember that famous things, water under the bridge? So here's the bridge, and here's the water. And you see the lymphatic channel going with the parametrium alongside the uterine artery all the way to the lymph node. And all what you need to do is just pick up that green node and take it out. If you look on the left-hand side, the dissection is way more aggressive. You're opening all the space, and you see all the anatomy. So way much more conservative on the left-hand side compared to the right. And the thing is, here's the result after 6 months. So you have on the left and the right-hand side, nice thin legs, and you have a lymphedema on the right-hand side. And as I said, there's plenty of studies. I'm not going to go through detail because of the time, but this tested it with the low-grade endometrial cancer, with the carcinoma sarcoma, with the serous uterine cancer, and even with the clear cell cancer, which is a quite very aggressive endometrial cancer. So all these trials, it did show that sentinel lymphadenectomy is quite safe, and the oncology outcome as good as a full lymphadenectomy. Now, if you're going to do a sentinel lymph node, you have to follow a certain algorithm. So the first one, you have to do a full inspection of the peritoneal cavity. If you find disease like this in the serosa, on the ovary, and the uterus, there's no point to do any lymphadenectomy. There's no even point to do any surgery. So you have to cancel it. You have to open the pelvic side wall, identify your sentinel node, and make sure you take the first one, not the second or the third one. If there's any enlarged node like this one, again, you forget about the sentinel node, and you take the big node, regardless if it's a green or blue or red. It doesn't make a huge difference. And like on the first example, if you cannot identify the sentinel lymph node, then you have to do a full lymphadenectomy. And the most important point is the last point. If you're going to do a sentinel node, you have to do ultrastaging for the node. Ultrastaging, quickly, what does it mean? Traditionally, the histopathologists, when they have a node, they just cut it from the middle, and they apply H&E, and they examine it. If you're going to do a sentinel node, you have to cut the node at very thin slices, 50 micrometer, anesthetic with immunohistochemistry to pick up what in new terms, like isolated tumor cells and micro metastases. I'm sorry for the time. I will go quickly on the adjuvant treatment, which is really the interesting subject in endometrial cancer. So traditionally, we do adjuvant treatment based on clinical and pathological factors, age, grade, histology, and depth of invasion. So endometrial cancer is regarded as low, intermediate, high, and high risk. And basically, if the patient is a low risk, like stage 1A with no myometrial invasion, there'd be no need for any adjuvant treatment. You can discharge them. If the patient intermediate risk, like myometrial invasion more than 50%, or there's lymphovascular space invasion, you give them adjuvant vaginal vault brachytherapy. If they're high risk, you give them pelvic radiotherapy. And for stage 3, you give chemoradiation. Now, again, innovation, we're moving away from this. So the proposed and what's used in some centers for endometrial cancer, we classify it into 4 different types based on genetic and immunohistochemistry. So you have the first type where there's a mutation on DNA polymerase called Pol mutant, and they have an excellent prognosis. So the 5-year survival for these women is almost 100%. You have the second group, endometrial cancer with mismatch repair protein. Those, for example, patients with Lynch syndrome, they have this mismatch protein, and they have intermediate prognosis. And then you have P53 abnormality, where they have poor prognosis. They behave more or less like ovarian cancer. And if you cannot find anything, you call them no specific molecular profile. Again, for the sake of the time, I will share with you this trial, which was published just 4 weeks ago. And we in James, we were part of it. And on that trial, we look, traditionally, women with low stages, they have adjuvant vaginal brachytherapy for all of them. So that trial is randomized women into experimental arm or standard arm. With the experimental arm, we divide them into 3 groups, either low risk, intermediate risk, or high risk. With low risk, no treatment. With intermediate risk, vaginal vault brachytherapy, and with high risk, external beam radiotherapy. And the way to reach them is what I explained before. And here is the Kaplan-Meier curve for these groups. For the first group with the Pol mutation, it doesn't really matter if you give them or you didn't give them adjuvant treatment. They have an excellent prognosis. So we don't give them anything, really. On the second group, where they have mismatch protein deficiency, it makes a huge difference to give them adjuvant treatment, and it improves survival. Now, with patients with P53, it was the group who benefit most from the adjuvant treatment. And you see a huge difference between the blue, where there was no adjuvant treatment, and with the red, where you have external beam radiotherapy. And with the group where there's no specific changes, it was equivocal. So most of the guidelines these days, like the ISGO, the ESMO, and the American Radiation Therapy College, all these guys recommend incorporating the molecular subclassification of endometrial cancer in deciding on adjuvant treatment. And I'm sorry quickly for endometrial cancer in young patients, because I think it's important for our country. If a woman had endometrial cancer, it does not always mean you have to do a hysterectomy. These women, if they want to have kids, they can manage with progesterone, but you need the strict criteria to manage them safely. And at the end, I would just like to say thank you to every one of you, but also thank you to my team in James's and all the sponsors. Thank you.
الله يعطيكم العافية. راح ناخذ بريك 10 دقائق، نرجع نكمل إن شاء الله. Good evening. يسعد مساكم جميعا. الآن بروفيسور ساهر صبري، تفضل.
Good evening. We are opening our evening session, second session for today, with inviting Dr. Sahir Sabri. Dr. Sahir is the Chief Interventional Radiology for MedStar Health and Professor for Radiology at the Georgetown University. He will give us talk about embolization for postpartum hemorrhage. Welcome.
شكرا دكتور. السلام عليكم. So I'm the not OBGYN in the rooms. I'm the interventional radiologist. So thank you so much for the invitation. This is my second time at this conference. Remember in 2019, this is when we had the first meeting. So it was great memories at the time. Thank you, Dr. Sufyan, Dr. Nihad, for the invitation. So I'm going to talk about postpartum hemorrhage embolization and just the role of what interventional radiology can provide. And we heard earlier talks about the issue of postpartum hemorrhage. So you all know this information, the definition of postpartum bleeding, and it's definitely increasing, and it's a major issue, with maternal death. The definition is loss of 1 liter of blood within the first 24 hours, regardless of road delivery, plus signs of symptoms of hypovolemia. And that's a definition. Usually it occurs in the early PPH occurs in the first 24 hours. And the most common cause is uterine atony, and that's the major issue that we deal with. And then you have the lower genital tract lacerations. Less common causes, which of course happens more commonly nowadays with the high C-section rates, the Akrita spectrum, and some coagulopathy. So, for conservative treatment, which is what all of you are experts in, and there's going to be a talk later on tomorrow about this topic and how to do appropriate fluid resuscitation, managing the hemorrhage with transfusion, and administration of either tonic drugs and tranexamic acid as options for treatment. And of course, all the other aspects such as uterine massage and packing and balloon tamponade. So all of these are conservative management that you all know. And this is a very good review in New England Journal of Medicine about the postpartum hemorrhage, and has the, these three areas of when the blood loss is liter to a liter and a half versus liter and a half to 3, and most of it is a conservative management. I want to, direct your attention to when the loss is more than 3 liters, and that is when the role of interventional radiology should be considered, which is uterine artery embolization for these patients. And I just magnify this. There's some major options such as bilateral ligation of uterine artery, of course hysterectomy as a last resort, but definitely uterine artery embolization should be considered before some of the radical aspects such as hysterectomy in especially young patients. So when can we, participate as interventional radiologists, especially in hemodynamically stable patients with refractory postpartum hemorrhage, also unstable patients, and there's some, ways that we can do it ahead of time with surgical management, especially for patients with Akrita, and I'll talk about that in the end. So I'll start with the first part. So uterine artery embolization is a procedure that is being done routinely. The procedure is very well refined, usually done from a femoral axis or from a radial axis. We actually did a procedure today at the Maqasid Hospital. We did an embolization for a uterine fibroid with Dr. Al-Zaghal and Dr. Abu Sharq. So it was a 45-minute procedure, very quick to do. So this is something that we can use as a rescue, and it's an easy procedure to do. And things that we look for is extravasation, pseudoaneurysms, and truncation of the artery. So as long as the uterine arteries are present and accessible, you can easily get into them by catheterization. And we use several particles such as gel foam, which is transient, or more permanent like particles, like it's called PVAs, alcohol type medications. And this can be repeated, and this is something that we've done and you can do it for both sides. So what do you do when you have postpartum hemorrhage? How do you manage it? So when we have a situation where there's it's refractory to medical treatment, especially after vaginal delivery, then what we do is we bring the patient in, we do an angiogram. We rarely see a specific abnormality like extravasation or pseudoaneurysm. So basically, we just empirically embolize both uterine arteries with gel foam. And gel foam is resorbable and basically recanalizes after 2 weeks. So this is something that is safe to do. And I'll talk about what that means and what the complications could be from it. But it's a very quick procedure to do. And you puncture one side, and you go and catheterize both uterine arteries and inject gel foam. And it can be done quickly. Sometimes when the source is not known, you can do a CTA to see where the bleeding is. And you see here there's a pseudoaneurysm that is in the lower uterine segment. In that case, we did an angiogram, and you see the pseudoaneurysm. And for these, you can put coils and basically exclude that pseudoaneurysm that was bleeding. And sometimes you may have to assess collateral flow, such as from the ovarian artery or the round ligament, and sometimes there could be bleeding from there. This is a case where there's bleeding that was, both from the the ovarian artery. You see this big tortuous artery. This is an angiogram of the aorta. You see a big tortuous artery. So that was contributing to the bleeding. And on here on the left side, the left uterine artery, you see major pseudoaneurysm with extravasation. So this is really hard to control any other method, and it's very easy to do with embolization. Basically, you put a little bit of gel foam, and that will take care of it, and takes a few minutes. And this was done similar for the right ligament artery, was bleeding, and that was treated with gel foam as well. So the technique is well studied and refined. So some patients who we may have to do if there's ligation of the uterine artery, procedure becomes much harder. And this is something that we always discuss. If you run into issue of a major bleeding, especially during C-section, ligation of uterine artery is one of the rescue methods that can be done. The problem with it is if it doesn't control it, then the procedure to embolize becomes much, much harder. And we've run into this issue many times where you go in and there's no uterine artery to embolize, but they're still bleeding through small collaterals, and these are much harder to catheterize. So this is a discussion that is to be had in the institution. If they have capabilities to do uterine artery embolization, it's a much easier procedure to do when the uterine arteries are open and much harder to do when the uterine arteries are ligated. So, and you have now to go through collateral. So this is something that we always discuss with our OB colleagues. The success rate for embolization for postpartum bleeding is ranges between 79 and 90%, and sometimes you may need a secondary embolization, and success for that is in the 80% range. Now I want to talk about a secondary causes of postpartum hemorrhage, patients that come later on, after between the 24 hours and 6 weeks. And for these patients, usually it's return products of conception or it's AVF. And sometimes you can't tell which of the two. Is it an AVF or AVM, or is it retained products? And you can do it by, you can take a look by ultrasound, and you see the findings within the uterine cavity. And sometimes you can do MRI, of course, as a beautiful finding that you can see. But of course, ultrasound can show you what you need to see. And for these, again. If there's a concern about an AVM, embolization works very well because of risk of curettage and bleeding from there. So there's always a good discussion about it, and if there's a thought that this is most likely an AVM rather than a retained products of conception, then we can do an embolization, and again, it's a similar procedure that is done and can be done late, within 2 weeks or later after delivery. So this is another case of a patient who had an AVM and that was embolized afterwards. So the other aspect I want to talk about is that CRETA spectrum. I think Dr. Martha mentioned this earlier about the rate that has increased significantly because of the high rate of C-section, especially in our area. And what we need to do. So you all know that CRETA spectrum, that CRETA, INCRETA, and per-CRETA. Of course, the worst is the per-CRETA, where there's complete invasion through the wall. And these are the ones that we really were worried about, especially if there's involvement of the bladder. And this is the lower uterine segment is, as you can see, has the bulging placenta. And of course, you all know the risk factor for it. And of course, the more C-sections you have, the higher chance that you're gonna have an CRETA spectrum. And of course, the risk of bleeding, ICU admission, infection, and of course, in surgery, injury to the bladder or the ureters. So the idea is it better to embolize or to deal with this on an elective or emergent basis? So, usually, incidentally found placenta CRETA of time delivery has a high mortality and morbidity. And trying to do a hysterectomy without prior embolization can have significant blood loss. So it's important to have early recognition and diagnosis. So how do you diagnose? Ultrasound works very well. A lot of these patients have low-lying placenta and previa. You can find lacuna and turbulent flow, and myometrial thickness of less than millimeter may also be seen. So these are some of the findings that we see with a bulging and abnormal placenta close to the bladder. Of course, MRI is definitely an excellent method of finding abnormalities, especially if you use gadolinium, and sensitivity is very high, as up to 88%. And you look for findings such as heterogeneous signal within the placenta, and then loss of differentiation and uterine bulging into the bladder. And here you do it with a full bladder and without a full bladder, and you see a low-lying placenta. And then on this coronal image, you'll see that there's loss of differentiation between the placenta and the bladder and invasion of the bladder. So going into this case ahead of time, you know that this is what you're dealing with, and then the planning for it becomes easier. So So there's some studies looking at what can you do. If you know you have a placenta accreta, what can be done? So there's several studies that have been done, some of them of putting balloon catheters inside the internal iliac arteries or before the procedure. So the patient comes in to the angio suite and they put catheters with minimal fluoroscopy, and then they go for their treatment. And then if there are any issues of bleeding during, after delivery, then they can come back to interventional radiology for embolization. So that is a process that's been discussed. And you know, some consider a combined procedure such as doing it in a room that has fluoroscopy, and you can do delivery, the C-section, and hysterectomy if needed, done at the same time. Of course, there's discussion about using the Roboa catheter, which is an aortic balloon that can be placed and inflate the balloon in the aorta. And that has been discussed in the literature as well as an option, and this is a hysterectomy after with patient after embolization. So there's a study looking at can you do these scheduled cesarean hysterectomy and doing it in a controlled circumstances, and this is a study of 76 patients and doing it in a controlled circumstances. And trying to avoid removing the placenta before embolization. So the process goes that you get ready for the embolization, you do the C-section, and then after, and leave the placenta alone, and then do the embolization, and then remove the placenta, and if you need to do hysterectomy at the time. So the idea is not to try to remove the placenta without embolization. So this is some of the cases from our center. And looking at some of the patients who were done without prior embolization and had up to 54 units of blood, and some of them were done when embolization was done and had very limited blood transfusion. So so planning it would work very well. So how does that work? I'm just going to go through the process that we have at our institution. The patient starts in interventional radiology. We place occlusion balloons, but we leave them deflated. Then the patient goes to the OR for C-section, and then we inflate the balloon. Then they try to remove the placenta gently, and if it comes easily, then that's it, it's done. But if there's any issues with the placenta, then it's left in place, and the patient goes to interventional radiology where they get the embolization, and then later on, they complete the last part of the procedure, whether it's removing the placenta or doing hysterectomy. So that is the process that we work through, and this is documented in the literature as a process, and it can be done at 2 different places. Do it to IR, go to the OR, then come back to IR. We're blessed that we have a hybrid room where there's a fluoro suite inside the OR, so we do the same procedure. The whole process happens at the same place, and there's no need for the patient to transfer. So I'm just going to show you quickly. This is the angio suite with the room, and this is done in interventional radiology. So it doesn't need to be, depending on the surgical exposure that is needed, and these units can be done and can be, the interventional radiology suites can be equipped with OR equipment. So this is the process. We have a NICU setup and everything is ready. And this is the back table that have all the embolization material that is needed. And then here we have occlusion balloons into each side from both axes bilateral, and we put the occlusion balloons. And then we do the, get ready to do the placement of the balloon first. And we use a very low frame rate so that we do not have any effect on the baby. So these are the occlusion balloons being present. This is, you see the baby, very low flow rate. And then afterwards we do the angiogram after the C-section before the placenta is removed, and we do the embolization. So this is embolization on one side, embolization on the other side. And once we're done with that part, then hysterectomy is done. In this case, the patient needed hysterectomy because of invasion of the bladder. And then after that, we do another angiogram before the patient gets off the table before closure. So this, has a very good effect. So quick question about fertility, after embolization. And it shows that, there's a decreased rate of future pregnancies, around 55% versus patients 93% who do not have embolization. But this could be because of the postpartum hemorrhage or because of the embolization. We don't know. But it's definitely something to consider, and comparing it to the other aspects such as ligating a uterine artery or hysterectomy. And in terms of other complications, usually they're very well tolerated. Just some buttock pain. Rarely could be some uterine necrosis and things like that. They are very reported. So the role of IR is to try to help with cases that have difficulty with bleeding and difficulty control. And fertility outcomes indicate that they can resume menstruation and there's a reasonable likelihood for future pregnancy. Thank you so much.
شكرا دكتور صبري، محاضرة قيمة وجميلة طلعت.
Would like to welcome again Professor Shandali with his second lecture, Screening for Fetal Malformations.
Perfect. Thank you very much. So I've been asked to talk about screening for fetal malformations in 25 minutes. So I will do my best. You could have talks for hours on screening for fetal malformations. So this is going to be a little bit of a whistle-stop tour, but I'll try and concentrate on what I think are the new bits of screening. The idea of screening is taking a large population in which there are individuals that require more attention, doing a test, and then enriching your population. And by that I mean that you see that up here there's just two. Oh, it's not. How did you? Hold on. Laser pointer. So here there's two, you do the test and you enrich the population. So it's not that you find everybody who has the issue, but you ensure that you're not doing perhaps an invasive test on all of these people, and you're only doing an invasive test on the smaller group with the more likely to have a positive result. So when we talk about fetal abnormalities, I like to think of them as either structural or genetic. And the structural abnormalities, as you know, are really occur in the early part of pregnancy when the baby is being formed. And the commonest one is cardiac abnormality. And traditionally, we have screened for these with ultrasound in and around 20 weeks. I think now with increasing ability to do transvaginal ultrasound, the machines and the probes are better, we can screen for structural abnormalities much earlier. But the idea of genetic screening has totally changed now because of our additional knowledge with regard to our genome. And I'll talk a little bit more about that in a moment. So we have been screening for a long time. Initially, we were screening for neural tube defects, and we weren't using ultrasound because back in the 70s, it was like looking into a cloud. The ultrasounds were so poor that you would really struggle, apart from anencephaly, to see small spina bifida or things like that. So we used maternal serum alpha-fetoprotein, which was increased in pregnancies that were complicated by open neural tube defects. And you had all this data, all these serum AFP values, and then somebody said, well, what about if you have low serum AFP? Could that be associated with something? And of course, it was associated with Down syndrome. And ultimately, there were other biochemical markers added to that to increase the sensitivity and specificity of those tests. But with respect to ultrasound and structural abnormalities, things haven't really moved on hugely. And indeed, in the Rotunda Hospital, for example, last year, half of our Downs babies were not diagnosed until after the baby was born. And that's because these babies grew normally, had normal hearts, and didn't have any gastrointestinal abnormalities, and we essentially missed them. So half of our babies with Down syndrome were diagnosed postnatally. So, as I said, really the key to screening for structural abnormalities is with ultrasound, and there's now a new guideline which can be downloaded from the clinical guidelines. If you Google Irish clinical guidelines, you'll find it. And we really have kind of focused on the heart, and we really try and ensure that there is a normal 4-chamber view and that the outflow tracts are properly aligned. And then if you use color Doppler, you can see here that that septum is really intact. Now, small VSDs you won't diagnose, and indeed 80% of them close during the pregnancy, but larger VSDs you would like to be able to diagnose. One of our challenges is that we don't always get the perfect views, and therefore we end up recalling people. And the commonest reasons for recalling people are that we were unable to image the posterior cranial fossa properly, we didn't get a 4-chamber view, we didn't get the outlets, we weren't able to be sure that the stomach was below the diaphragm, and therefore to outrule diaphragmatic hernias, and we didn't get adequate views of the kidneys. The bladder we can usually find all right, but this is a huge problem for us, obesity. And in Ireland, obesity is very common, and it makes the structural anomaly scan really challenging. And it's actually very hard to communicate that to these women. They say, well, why can't you see it? They say, well, there's technical reasons, you know, and we don't really try and get into that. We kind of fudge it, you know, but obesity is a real problem. In the rotunda, we have, these are our detection rates. So anencephaly, we would have 100%. Cardiac abnormalities, which we have particularly focused on, and Professor Fionnuala Brannock is largely to thank for this. We have 91%. And then things like lethal skeletal dysplasias we're not so good at. So the Rotunda Hospital, as I was saying earlier, is the longest running maternity hospital in the world, and it's the busiest maternity unit in Northern Europe. And last year, we did over 31,000 ultrasound examinations. So I'm going to leave the screening for structural abnormalities there and move to genetics. When we think of our genome and our genetics, we kind of traditionally think of chromosomes. And indeed, when you looked at chromosomes over the past 30, 40 years, this was what you found. And in this karyotype, there are actually 3 chromosome 21s. But you'd really need to be a very experienced person looking down a microscope to be able to distinguish chromosome 1 from chromosome 2. So the ability to do that really resided within the individuals that were doing it. And things did get better when we did banding, and we were then able to get resolution down to 7 to 10 million base pairs, whereby you could look at the banding patterns of different chromosomes and say, there's a bit missing there, or there's a bit duplicated there, but really it was on the large scale. And then over the last 20 years, we were able to chop the chromosomes into thousands of pieces and compare that test chromosome sample to what was regarded as a normal one and see was there differences. And that's known as copy number variance. And now you could get down to 500,000 base pairs. So we were getting more and more information. And then 20 years ago, we finally decoded the gene, our genome. And we have 3.2 billion base pairs within our genome. So if you were to stand up and read them out aloud, it would take you 9.5 years. So we have a huge amount of data now, and how do we incorporate that into our screening paradigms? So let's talk about Down syndrome, because that was really the first genetic problem that we screened for. And we used maternal age. And as everybody in this audience knows, as a woman gets older, her risk of Down syndrome goes up. So we could use maternal age. And then Kypros very kindly offered us an additional screening method, which was nucotranslucency. And we have two of Kypros's fellows here who I was talking to Firas earlier. And nucotranslucency is still a method of screening for Down syndrome. And what this slide shows you is that at a 5% false positive rate, how many procedures would you need to do for a screen-positive individual in order to find a baby that had Down syndrome? And, you know, I must say, I kind of feel a bit uncomfortable about this, you know, because we're not hunting the Downs. We are definitely not hunting the Downs babies, but we have screened for Downs babies for a long time. And all of us, I think, believe that our children should contribute to society, be loving members of our family, and virtually all the Downs children that I know fulfill those two characteristics. So it's not about hunting the Downs. This is about a scientific discussion about screening. So we had this test here, which was the best that we had available, which was measuring the nucotranslucency and adding biochemical markers to that. And that had a detection rate of 87%, but you were still doing 25 CVSs or amnios in order to find one positive. And then in 1997, Dennis Lowe found fetal cells within the maternal circulation, and that is a game changer. So that when you add that screening test, you're now doing only 4 invasive procedures to detect an affected pregnancy. So it's hugely different. And the benefit of that is that you're not doing 25 procedures or 50 procedures, that you're doing far less procedures, and therefore you're not exposing all the other women to a procedure that carries a pregnancy loss rate. So it is highly efficient. The sensitivity for Downs is 99%. The positive predictive value in a 40-year-old is 87%. But in a 25-year-old, it's only 33%. And the ability to counsel women is totally predicated on what the positive predictive value is. But when we're screening for fetal abnormalities, it's not just about Down syndrome. So there are quite a number of other abnormalities, particularly microdeletions and duplications, which actually are far more common than Down syndrome. And when you look at this slide, it's not until a woman reaches 40 that Down syndrome is actually more common than microdeletions. So why are we concentrating on Down syndrome when perhaps we should be giving people information about other congenital abnormalities? But we now know that there's 3.2 billion base pairs within our genome, and therefore single gene disorders we can now potentially diagnose and screen for them. Single gene disorders account for at least 10% of pediatric admissions, 20% of infant mortality, and their prevalence in North American women is 1 in 280 births. Down syndrome is 1 in 800 live births. So while these individual genetic problems are rare, the actual burden on the patients and their families is huge. So should we be screening for genetic abnormalities? Should we be looking to find these single gene disorders? This is the front of Time magazine in December 2012. And it asks the question, want to know my future? So would you really want to know that at 40 you're going to develop the complications of some rare gene disorder? I'm not sure you would, unless you could do something to mitigate that risk. So we do need to stand back from this and see what we're doing and ask ourselves why we're doing it. Because non-invasively, we can now screen for these genetic disorders. They're not so much commercially available yet, but that will come. So in the rotunda, if we look what's happened since 2015, when we were doing a lot of screening using the combined test, the PAP-A, free beta HCG, and the nucleotranslucency, that has now been replaced by non-invasive prenatal testing or cell-free fetal DNA. And when you do these tests, the important thing is the positive predictive value, because only then can you adequately counsel a woman. Now, is it going to work? Oh, I need to take the thing off. Hold on. Sorry. Hold on, I need to. I need the, I don't. Sorry about this now, just bear with me. Yeah. No, it's not that. Yeah, you should have. Yeah, maybe that's it, is it? Arrow options, maybe. Oh, yeah, there you go. Oh, brilliant. You're a genius. So, this is what we do. So we access the Perinatal Quality Foundation, or Perinatal Quality Org. Oh, great. Okay. So this is a website that has been put together by the Society of Maternal Fetal Medicine in the US. And it allows us to use an online tool . Let you do it. Okay. So you get into this screen, and can you go to PPV calculator? So you have chromosome condition. So if you just click on that, you'll see there's a whole variety of different chromosome conditions. And all of these are actually quite rare. So these are microdeletions, but they're rare. Now, the only thing about screening for these is that women come to you looking for reassurance. I have not met the woman who has come to me for a screening test who's looking to find a problem. So the negative predictive value of all of these is very high. The problem is that because the prevalence is so low, the positive predictive values are very low. But if we just go down to Down syndrome, trisomy 21, up at the top. No, up at the top, trisomy 21. No. Trisomy, yes. Okay. And then maternal age at expected date of delivery. Yeah. So put in 25. Okay, and calculate. So this is the positive predictive value. So if you have done one of these screening tests on a 25-year-old woman and she has screened positive for Down syndrome, you can actually now counsel her that there's only 50% of the time that this is a true positive. And in that situation, many women would perhaps decide not to have a CVS. You can do these screening tests from 9 weeks. So you're looking at doing CVSs, which carry a loss rate of perhaps 0.5%. But frequently, women decide, no, I won't do it. I'll wait. I'll have an amniocentesis maybe at 16 weeks, which I think we would all believe is a much safer and easier to do procedure. And I'll wait and do ultrasound and see if indeed there are any structural abnormalities, and we know there are many structural abnormalities that are associated with Down syndrome. Okay, and I'm almost there. So I honestly believe that screening for fetal abnormalities, for structural abnormalities, it's about ultrasound. For genetic abnormalities, it's about non-invasive prenatal screening. And that we really are obliged to calculate positive predictive values before we talk to women, because women may decide not to have an invasive test, or at least not to have a CVS, but to wait until later in the pregnancy to have an amniocentesis, because as you can see, for this particular woman, her risk of Down syndrome is exactly the same as her risk or her opportunity that the baby is normal. Thank you very much. Oh, another photo, okay.
Thank you very much. We appreciate your knowledge and your cooperation.
It's my honor to introduce Professor Elvira Pratilla, Head of Department of Obstetric and Gynecology at University of Medicine and Pharmacy, Carol Davila, Bucharest, Romania, President of Romanian Society of Urogynecology, and President of East European Endometriosis and Infertility Society, for her first lecture tonight. Perineoplast, aesthetic reason or part of pelvic floor disorder.
Thank you very much. Thank you very much for invitation. I will present my first lecture about perineoplasty. Actually, there is a question. Perineoplasty is an aesthetic reason, or should be part of prolapse surgery? Along development of aesthetic gynecology, vaginoplasty become evolutionary term of classical term of colporaphy, and reconstruction of perineal body replace term of perineoraphy. Let's take a look at the anatomy and look at the picture of Professor Petros that published when he published the integrative theory. You all know the relationship of vagina cranially with Douglas punch of sac, and posterior with the rectum, and inferior with perineal body. But the problem is, there is rectovaginal fascia or not. Most of the anatomists and even histopathologists doesn't believe that there is rectovaginal fascia comparing with anterior compartment when you have vesicovaginal fascia. If we look at the pelvis, we imagine the pelvis in 3 compartments. Anterior one with the bladder and urethra, the medial one with the uterus and vagina, and posterior with the uterosacral ligament and the rectum. In all these compartments, we have 3 levels of support system. The level 1 that support the uterus and actually half of the vagina, we have anterior pubocervical fascia and pubovesical ligaments, and in posterior part, uterosacral ligament, and all this anterior and posterior support system attached to the cervical ring. Cervical ring is the key of the support system of the uterus and vagina. At the level 1, we have pubouretral ligaments and arcutendineus and the rectovaginal fascia, and at the level 3, external uteral ligaments and the perineal body. These are the support system for posterior compartment, and when all these systems are weakness, can produce different defects. For example, when uterosacral ligaments are weak, we have uterine prolapse and superior rectocell and enterocell, and is associated with stress urinary incontinence and posterior compartment syndrome. And I will talk a little bit at the end about this. When we have defect of the tissue between the rectum and vagina, if you want to call rectovaginal fascia, you have rectocell. And defects of the perineal body, we have flat perineum. And the defect of this perineal body, you can assess with clinical exam, with the rectovaginal examination, and you will feel soft perineum. And all the defects you can assess with ultrasound, transperineal ultrasound with a convex transductor parallel with vulvar. Very easy, you can assess the perineal body if it's necessary to repair or not. And you can assess the rectocell and even the elytrocell. We have two types of rectocells. This is important to know, the superior one and the inferior one. The superior one is associated usually with enterocell and is necessary to repair. When we repair it, is necessary to reinforce the uterosacral ligaments. The low rectocell, it's not a must of repair during pelvic floor disorder repair. You know why? Because I will explain a little bit later. If it's not very large and you will not have empty dysfunction, it's not necessary to repair. The surgical indication of the low rectocell is for the large low rectocell when the patient fails to empty the bladder, the bowel. And most of the surgeons do the repair of the low rectocell always when they repair the prolapse. But imagine that you do colposacropexy or repair the prolapse laparoscopically, and the low rectocell is not very big, and the effect of the perineal body is not very big. It's not necessary to turn vaginally and repair the posterior perineal body if there is no aesthetic reason and the patient has no other dysfunction. Because I talk about rectovaginal fascia, I want to show you a video with the fascia in anterior compartment and posterior compartment. It's a video with minimal invasive surgery prolapse repair. You can see anterior vesicovaginal fascia is very clearly seen during surgery, and we can identify, we can repair, usually in superior cystocell. The fascia is detached from the cervical ring and we can reattach it, and in cystocell we can put threads, unresorbable threads to repair the fascia. Sure, you can do the surgery vaginally, how you prefer, but I show you the video laparoscopically because it's easier to identify the fascia. Let's take a look in the posterior part. This is a decollation of the rectovaginal compartment. You can see it's not really a fascia. The conjunctive tissue, it's soft, it's loose, actually between the rectum and vagina, what you are called fascia, it's the serosa and muscularis of vagina. In this video, it's a different patient. It's a patient with endometriosis. And you can see how this tissue become more dense because it's endometriosis of the space between rectum and vagina. She has a bowel nodule. So this conjunctive tissue can be modified during inflammation and during some pathologic disease. About the repair of low rectal cell, you all know the technique proposed by Petros, posterior vaginal bridge, to reinforce the tissue between the rectum and vagina using a bridge of vaginal mucosa that is left in place and is attached inferiorly by perineal bodies. The perineal body is reconstructed with transverse resorbable threads. And this is a technique that I usually use when I repair the perineal body and rectal cell. It's not part of all my prolapse surgeries, only when it's big, when it bothers the patient from the aesthetic point of view. I start with first to design the landmarks. First one as a hymeneal ring, another one where labia minora reach the vulvar fasciata, and the cranial part is cranial part of the defects. I start with a dissection with the vagina from the rectum, and because it's not really a fascia between the rectum and vagina, I put the first layer of thread in a deep layer of vaginal wall. I usually use 3/0 thread resorbable. You can use V-lock, it's very good because after I dissect the rectum from vagina, the thread, I put the thread in a continuous manner, and I think it stopped. After I finish the whole vaginal defect, I continue at the perineal body, but in a longitudinal manner. You know why? Because maybe all you saw when you put transverse threads in the perineal body, actually is not reconstruction. Actually, it's a fibrous tissue after the surgery. With these continuous threads, I reattach the vagina to the perineal body. And another result of this, I elevated the perineal body. This is important because in this manner you can reconstruct the vulvar fasciata, and really you can create a very good aesthetic reason. And the second thread will be in a submucosal part of vagina, and at the level of the hymeneal ring, the both threads are tied together. I use V-lock because it has 2 needles, and with one thread, I'm going in the profound layer, and with the second thread, superficial. And in that way, you can reconstruct the low rectal cell, and you can reattach the perineal body, and without creating fibrosis. Because as you know, perineal body, it's formed by profound and transversal perineal muscle and some fiber from bulbocavernous muscle. It's not actually fibrous tissue. like you create it after you put the threads. So the aesthetic and functional results, it's very good. So the principle, if you decided to repair the low rectocell and perineal body, is to restore the distal vaginal wall defects, to reconstruct the valvar fourchette and perineal body, to raising the perineal body and reconnecting the vaginal wall to the perineal body. And to conclude, and to answer at the question, is it really necessary to repair the low rectocell and perineal body if the defect is not big and is not aesthetic reason? Let's take a look at the diagram of Peter Petros. What kinds of defects and what kind of symptoms can produce? For example, in the posterior part, the uterosacral ligament defects can produce prolapse and enterocell, and like symptoms can produce stress urinary incontinence and posterior syndrome. Posterior fornix syndrome means nocturia, pelvic pain, and erythrocell. This is very important when you assess the patient because the surgery is very easy to make a high application of uterosacral ligaments. So the reconstruction of perineal body, the purpose of this procedure is not to restore the integrity of the perineal body as a fulcrum from posterior and caudal muscle force vectors. Perineoplasty reason is for aesthetic reason and only in large rectocell and in large defect of perineal body. Thank you very much.
Thank you very much. We appreciate your coming and your knowledge. الرجاء الجميع يتقدم لهون عشان نعمل صورة جماعية. إذا سمحت. Please come for a group picture.
يلا يا شباب، يلا عبير، يلا عبير، يا بندبر حالنا، وقفوا هون.